to an early mobility grant to really lead the peaks region, let's see if I'm going to get that terminology right, in this work, and then hopefully develop it here and then spread it. I think over the years, St. Joe's and Good Sam have had times where they've walked into patients where they've done what we would call a full-on early mobility in the ICU program. None of our other 8 sites have ever done that. And no one's done it in a sustained manner. Somebody leaves and the program falls apart. So what we really want to do is help, and that's part of the reason we have someone from PI here, is to keep this going, embedded in practice, make it normal. One thing we do have now that we didn't when we wrote the grant is the LDS Hospital in Salt Lake City, which is the Intermountain Hospital, is really internationally known in their early mobility in their ICU. They don't sedate their patients after intubation, they pull them right out, and they give them pain and anxiety meds. They have patients playing guitar, you'll see some videos walking around. It's called a walking, waking ICU. And they've been doing it for, I think, 30 years, 25, 30 years, so it's very embedded in their practice. And so I was given permission by the VP of my department to reach out to one of their key PT, OT, and nurses. I emailed them yesterday to follow up pattern and how we start connecting with our Intermountain Health colleagues. So I'm hoping to reach out to them. Maybe we won't have to reinvent some wheels if they're already doing something. I did learn that has not spread beyond that LDS hospital at Intermountain. It's just there that they have this very, very class, world-class ICU early mobility program. So this grant, it falls within a series of Mobility Matters grants. So we have that ambulation work that you see now, and the measure of ambulation on integrated quality scorecard that are looked at to get those patients that come in that are walking, so we don't disable them. What we do all the time, actually, I see reports of this still every day at some of our hospitals. We have a patient come in who can walk. We don't let them move while they're here, and then they can't leave. Their length of stay is longer. They've debilitated. A lot of them can't go home that were at home. We had sent them to skilled nursing. So we started with that first, was just that low-hanging fruit, those patients we disabled when they came in here. And we focused on 65 and older because we disabled them most rapidly. And then we moved to lower level ambulation and lower level activity. So our BMAT 1 and 2 patients and keeping them active, and we're working on that. Both of those are piloted at Lutheran. And now the next thing is going back to that critically ill patient. And so that's where this kind of fits into that big picture of really that safe mobility, that we're going to maximally mobilize all of our patients to their capability, not to our capability of mobilizing, but to theirs, and to do it without hurting our caregivers. So using technology and without our patients falling. So again, using technology when that's appropriate. And so that prevention of falling isn't to have one of your coworkers be a machine for you, but to have the machines be machines. And so using that technology so that we're not saying, yeah, let's just throw another caregiver at it, we can hurt them, because we have plenty of caregivers around the country these days.
Right.
And so that's kind of the big picture of where this is fitting in, and looking for you guys to really lead the way in the ICU early mobility, hopefully with some help, of some of our counterparts now at Intermountain and Salt Lake. So welcome, and I guess some of you know me, some don't. So I'm a PT by background, and I've been working for legacy SCL Health for about 15 and a half years. And I have done ergonomics and consulting in industry and in healthcare. I've been a PT for 33 years. And so, and I work in all areas. My specialty was outpatient orthopedics, spinal, manual therapy, and rehabilitating people to go back to work that were injured on the job. And treated a lot of PTs, OTs, and nurses when I worked in Boston who were injured moving patients. And then kind of evolved, did a lot of ergonomics in industry, worked on site at a lot of big companies, Raytheon, Reebok, FootJoy, treating and doing ergonomics. Their employees are doing ergonomics. And then about probably around 2004, went solely to just healthcare ergonomics and then safe patient handling and mobility for clinical ergonomics to help that. And so you'll see today we'll be talking a lot about, it's not just mobility, it's safe mobility. A lot of times we're not going to maximally mobilize a patient because we're afraid they're going to fall, and that's real. I know I'm afraid of what people are going to fall, or that we just physically can't handle it. We're walking with that patient, we're like, you know what, I'm going to just stop right now because I feel like this this is the safe time. And that patient might have been able to go further. So if we have them in a walking sling and a lift, you get them to tell you what the endpoint is, not what you're guessing it might be. So again, how to use technology to really make mobility safe so that we're maximizing our patients' mobility, but we're not injuring ourselves or our patients. So that's the big picture. And so I'm the manager of caregiver safety. And so I oversee all employee safety. And so this is one component of it. And this is where I'm most passionate. I think about being a PT, I want to see people move. So anyway, what I'd like to do is have everyone just go around the room and introduce themselves, what their background is, where they work right now, and then why they're passionate about this. Or I was told to be here, and that's totally fine.
Fine too. Yeah.
Whatever that is. We'll go ahead and start with you if you don't mind.
I'm Rachel. And I think it's just as an ICU nurse, so many of our patients truly aren't able to get end of life. But it's really encouraging to see once they do better. There's just something about seeing people walking in here, just so like it's super selfish to see and to see them.
You're right, and it's rewarding for them, isn't it, and the families. Yeah.
Well, and it helps with burnout, which we see hugely these days, right? It helps with our own employees not to get burnt out when they can see some of that.
Mm-hmm. Yeah. Anna, also a nurse here. I was told to do this, but I also think it's pretty interesting. I agree with her. It's rewarding to see some of our patients walking. The majority of them don't make it out. So.
Yep. Wonderful.
My name's Trent. I'm a PT here. I worked at a couple different hospitals where early mobility was not a thing at all. So coming here, I thought it was really in place. So I think it's cool to hear that there's still some more that we can do. Also do wound care. So see a lot of patients in ICU develop pressure injuries. So I think it's also very important on that aspect.
I'm also a PT. My name is Morgan, and I'm here. And I think it's just also like echoing, like it's gratifying to be able to be the one to kind of help people like stand up for the first time or walk for the first time after like a serious illness or trauma or critical illness. And we all know how important that is. So I'm hoping that this kind of reinforces that.
Right. Thank you.
I'm Brenna, I'm an occupational therapist here. I'm also the ICU specialist for the PMR department. And I'm really passionate about the mobility because just seeing the impacts of delirium on my patients, and that's what I go in and I work with most serious patients. Preventing that before some of the problems through mobility is something I really want to start doing.
I'm Dylan. I'm an internal medicine resident. And I guess I'm passionate about this or interested in because I know there's a lot of studies showing that just to stay in the ICU has a lot of negative long-term sequelae, like weakness, negative outcomes, and just relatively simple or something you can do while they're in the state to improve their outcomes.
Perfect.
I'm a native hospital respiratory therapist here at St. Joe's, and my passion is really just to echo what we heard from everybody. It's just the gratification of seeing the patients improve at a more quicker rate.
Thanks.
My name is Scott Klein. I'm a performance improvement specialist here at St. Joe's, and I'm both interested in improving the clinical care of our patients.
Oh, that's great.
But right now, I think probably my best contribution is to help make sure that this program goes out easily and smoothly and sustainable.
We already have some jobs for you starting tomorrow.
You said that is your goal. You want to do that, right? Wonderful. Great.
From my perspective, decreasing costs of opiate use and just costs in general for the pharmacy.
Great.
I'm Aura. I'm one of the intensivists here. I work for Pfizer. I see these patients both in the ICU and then they get to see them in the clinic, and I can really see some of the long-term effects, kind of like what Dylan was saying, on the patients, kind of months and even years out from their critical illness. So, you know, myopathy, neuropathy, delirium, mental fog, all of those things. I feel like that's something that has been shown to be avoided with mobility. So we're excited to help out.
Excellent. What a great interdisciplinary team we have here. So I'm Margaret Arnold. I'm a physical therapist by background, by training. I did my training in Scotland and about 30 years ago, came to the States, and I got involved. Initially, my work as a PT was in industrial rehab. I treated a lot of the people in my hospital in Michigan, neck, back, shoulder injuries, and so I became an ergonomics specialist, and I was voluntold I would chair our ergonomics committee. That was back in 2002, and so through that, I realized that most of the people that we were seeing were our own nurses and therapists who were getting hurt moving patients. So I got into the safe patient handling route that way. I said, okay, this isn't okay. We need to do something about this. Always been a data geek. I've always been just, we've got to measure it. We cannot do what we don't measure. And as human beings, we do what we're held accountable to, right? And what we're measuring. So through the Safe Patient Handling program, I started a program at my hospital back in 2006, and we reduced our injuries by 95%. It was a very successful Safe Patient Handling program. But as I was doing rounds and on the units, I recognized how little our patients were getting up. And that was right when Intermountain Health was just starting some of their Polly Bailey, and they published their 2007 a seminal article on the safety and feasibility of getting patients up in the ICU. So it was right around that time. And so we started an early mobility program. And so now I have a company called earlymobility.com, and I eat, live, and breathe, and I am a complete and total geek for this stuff. So you'll hear that this morning, because you are all right. What we can do in preventing our patients is absolutely life-saving for them and absolutely life-altering for our patients. And it is so rewarding. Initially, it seems difficult when the culture has not been to get them up. It seems like many of our patients can't. But as you start to do more and more, you realize that more and more patients actually can than you thought they could. And like you've said, the long-term outcomes are just unbelievable. So what we're going to do this morning is we're going to talk, first of all, about some of the physiology. We're going to get a little geeky initially, but it's important, I think, to understand what's going on with that immobility. Why are we seeing these outcomes? So that we can really relate. And some of the information we're going to share is going to be more relatable to you than others. So as we go into it, think about for yourself what pieces you pick up on, because if you're teaching other residents, if you're working with other new intensivists that are coming into the unit, the goal with sustainability here is that every new person who now, from this day forward, we never go back, right? Every single patient now is assessed for RAS and CAN every single day. We're assessing them for mobility every single day, and that new people that come on get this same training. And that's going to be one of the things that as champions, you'll be helping to do. So thinking about what's going to really stand out for new residents, new interns, new PTs, new OTs, new RNs, new, RTs coming on board. The other thing I want to share this morning is I want to make sure that everybody knows this is a safe place to ask silly questions. There is no such thing as a silly question. Right? Any question that you have. One of the things that I am passionate about is we feel we can't ask questions. We feel like things are presented and we're supposed to know the answers to all this stuff. And so there's a fear in healthcare to ask questions that we feel our counterparts think we should already know. Ask those questions. We're going to be doing practical hands-on later. This is the place that it's safe to make mistakes and to get it wrong. That's why we're going to jump into actually doing it and applying some of the stuff that we've learned, okay? Any questions before we jump into the content?
And also bringing up barriers. Oh, sorry, go ahead.
I was just saying, I'm Patty, and I'll be here later, in and out and tonight. So I'll see you guys around.
Super.
Thanks, Patty.
Thank you.
Yeah, and also, challenge things and bring up concerns and barriers, because the only way for us to really change things long term is to truly hear the hard stuff that I don't think we're gonna be able to do this stuff. Like, bring it up.
Absolutely. I call them the yeah buts, right? This is great, but think about everybody on your unit that you're going to go back with. What are the reasons they're going to tell you they can't do this? because we're going to engage those and just work through them. And we're not going to get to waking every patient up tomorrow, right? We're going to start with the low-hanging fruit. We're going to start easing into it. We have to meet staff where they are. And we can have a vision that is as big as Mars. But if people can't relate and can't see the little things that I can do in my shift today, if it seems too big, they just won't do it. Okay, so that's the other part as champions, is to take a little bit of it. Where can we start tomorrow? When you leave here today, what's one thing that we could do today to start making a difference? And so we're going to talk about that throughout the morning. Okay.
And Scott, as you listen to this, with your PI expertise, you might be able to help guide us on some of that.
Definitely.
Yeah.
So I'm going to start with about 5 minutes of this podcast, and a couple of you may have heard this the last time I was here. This is from a nurse practitioner. She's a DMP who actually mentored and trained at Latter-day Saints as part of Intermountain Health. She worked in the walking awake ICU, and so let's listen. This was one of the things that caused me to say, no matter what the barriers, no matter how high, no matter how wide, we have to break them down. We have to find a way. So I'm going to just have us listen to this.
Exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. Hello and welcome to our first episode. I'm a nurse practitioner, and as a nurse, I started my career in an ICU that allowed patients to be awake and mobile. It was normal to have patients on breathing machines be awake, sitting in chairs, communicating, and walking the halls 3 times a day. During my first few years there, I felt like a handful of patients ended up with tracheostomy or having to be discharged to an hospital rehab. When I became a travel nurse, I was suddenly exposed to the traditional practice of sedating all patients on ventilators. I once asked the doctor if I could wake my patient up and walk them. He looked at me in horror and asked if I planned to follow him with intubation card. It was then that I realized that our experiences and exposure ultimately influence how we manage patients on ventilators. As a travel nurse, I shrugged my shoulders and took on a win and run approach and complied with the nuances of each hospital. I even found myself innocently laughing at instances of sedation as a joke. Even though I had seen what it was like to send patients straight home from the hospital, as a nurse, I was still unaware of the magnitude of impact our practices have on patients' lives, families, careers, and futures. That understanding came years later as a doctorate student. The impacts of sedation and immobility were never mentioned by a single professor during my 3 years of graduate studies in acute care medicine. It was an actual ICU survivor on a plane ride that revealed the truth. When I told my new companion that I was an ICU nurse, the color instantly left his face. He then spent the next hour telling me about his experience in the ICU. It sounded like he had perforated his esophagus from a procedure that led to pneumonitis, severe septic shock. He was intubated on the ventilator for weeks or more, but that was his main concern. His description of the worst part screamed to me, ICU delirium. With tears rolling down his face, he tried to explain what it was like to have his legs nailed to the ground in the middle of a forest, unable to flee from falling trees, cropping down on top of him on repeat. He later found out that it was an ear temperature probe, not a gun, that plugged into his head every 2 hours. Each time he would brace himself to have his brain blown up by the gun, only to hear a click, and left the assumption that it was not a bullet, but would be loaded next time. He couldn't tell me everything. It sounded like what he had shared already was causing him anxiety. He had to go to rehabilitation to relearn how to walk, talk, swallow, and eventually have his tracheostomy removed. When he was finally home, he continued to relive those images of horror every time he closed his eyes. The depression and anxiety from PTSD, along with the insomnia, sent him into a psychotic spiral. He said that his ex-wife, who he referred to as the love of his life, had slept on the floor of the ICU for those weeks and fought it all right with him. Yet a year post-ICU, he found himself not at all himself. divorced, and alone. This discussion occurred about 4 years following the event. He was still unable to resume his career, and judging by the deep despair and emotion he expressed, he was not free from the trauma. At 48 years old, with no real comorbidities, my new friend had declared himself a DNR DNI. He said, I know I sound really ungrateful. I feel guilty for feeling this way. I would be glad they saved my life. But my time in the ICU ruined my life. My marriage, career, and life are ruined. If I'm ever sick again, no matter how reversible it is, I would rather die than cross a toe back into the ICU. I sat dumbfounded and had no response beyond crying with him. I had no idea. I had worked in the ICU for 5 years and had never heard anything like it. I couldn't help but think back to the patients that I had sedated during my travel. I felt haunted. This was not what I had signed up for. Like almost every other professional in the medical world, I had chosen to become a nurse because I wanted to help. I aspired to alleviate human suffering and even save lives. I still didn't know what this all meant or what to do with this information until I had a contrasting experience. I was back in Salt Lake and in the cafeteria of a hospital when I heard someone yell my way, I thought I knew you. I turned around and really recognized the woman talking to me. Her face, the hands, the fingers, and then it all came back to me. The room, the ventilators, and pneumonia, the anxiety, yes. She was tough, but so was I. And I was suddenly living this flashback of really pushing her to walk on the ventilator while she sat at the side of the bed and trembled with fear. At baseline, she used a motorized scooter and was really weak, so her acute ventilator dependent. Her crystal ball had trach and peg written all over it. Suddenly she interrupted my thoughts with, you were so mean. You made me walk when I was tired and scared, and I thought I hated you. Yeah, I couldn't deny that. And I didn't know how to smooth that conversation over when suddenly she reached over her walker and had me in a bear hug. You saved my life, and I love you. That moment penetrated me. I remember that her main goal and focus was to get home. What she meant by you saved my life was not that I just kept her on the ventilator. She got back to what her life meant to her. She had a value. She went home to her partner and her dog. She taught me that is what it means to save a life. This survivor friend understood before I did that saving lives in the ICU is done by preserving function and allowing a full restoration of their lives as a whole. That is what this podcast is all about. It is about how to save lives, not just specific organs. The ICU I work in that social indicators all treatments to that. Therefore, 98% of our survivors walk themselves out of the hospital doors and go straight home. We will be learning about this from everyone involved in the process in the ICU team. We will hear from nurses, respiratory therapists, doctors, nurse practitioners, physical therapists, pharmacists, occupational therapists, speech therapists, and especially survivors and their family members. We will talk about our experiences a little off the books as well as dive into the book. We will be dissecting and yet simplifying current research to make it come alive and mean something.
So that was one of the podcasts, and she has 100 or more podcasts, and you've got the link on in your PowerPoint. It's a lot to digest, but I listen to them in the car. Her work is amazing. This is Kaylee Dayton. She works, she's now a consultant, and this is the work that she does, is helping everybody around the country and around the world. Her goal is that all of us move closer to what they're doing at that facility. So let's go back to the presentation. Any questions on that or comments? Pretty powerful stuff, huh? And what we're learning is it's not just that one patient. thousands and thousands, millions of patients are living this experience every year because we just don't understand the horrors of delirium and deep sedation. We think that when we're putting patients into a comfortable sleep so they don't remember the trauma of the ET tube, what patients are telling through these podcasts over and over and over again is, it is much more traumatic for me. I'm not sleeping. I am in living hell when I'm in sedation because I'm having hallucinations, I've got disorganized, I don't know what's going on. Many, many patients think they're being raped, they're being kidnapped, they're being held hostage, and this becomes their reality for the rest of their life. So that's my passion behind what can we do today to start changing the way we practice and the way we do things. So this is just another example. And you've seen this before, but this is not so much the ICU, but there's lots of opportunities for mobility. And it's what Nancy talked about before, where patients are going from independent, mobile, active, to dependent on a walker, relying on somebody else in a very short period of time. And it transforms their lives. And there's lots of opportunities throughout hospitalization for us to make a different decision, to be mindful in that moment. Do I up sedation or do I try a different strategy? And really the biggest thing, the biggest takeaway from today is delirium is bad. Deep sedation, how can we avoid it? Can we avoid it in more of our patients and have them more awake and able to be mobilizing more? That is the bigger picture question. How can we do that together? So I'm going to go in, this presentation is a little bit of the physiology. What's going on with immobility specifically in each of our body systems? PICS is the new or worsening physical or cognitive impairment after critical illness. It affects patients and their families. We also know through some work I'm doing in the VA that it impacts suicide and depression in both the patient survivors and in their family. It changes relationships, it changes social, the way people can socially relate to their environment. They're not able to work, they're now reliant on their spouse. Their spouses often have to give up work or have a caregiver now, so it impacts them economically, it impacts them in every aspect of their life. The biggest causes are, as you mentioned, ICU-acquired weakness, cognitive impairment, and delirium. Those are the top three factors. And the question is, to what extent can we prevent? We know that not all of it is preventable. Let's start with the low-hanging fruit. Where can we start to reduce this? ICU-acquired weakness and delirium is a complex interplay of underlying pathology and pre-hospitalization status. As we know, inflammation and coagulation cascades from the systemic inflammatory response, sepsis, septic shock, multi-organ dysfunction syndrome, and inactivity and immobilization. It's not one or the other, but each of these has a synergistic role on the other. And then pharmacology, side effects, normal processes are dysregulated. And if you think about it, all of us are designed to be dynamic and active, right? We are constantly challenging and providing stimuli to our vascular system, our lymphatic system. We're constantly having a dynamic shift in blood pressure that requires our medulla, requires our brainstem to have adaptive responses. Even if you try, and everybody try and sit absolutely still, don't move. Is anyone sitting absolutely still? Right? Even where there's constant, very minor changes, our proprioceptive system, our inner ear, our vestibular system is consistently and continually all the time responding to the dynamic nature of us being dynamic beings in gravity living on planet Earth. So when we remove those stimuli, those systems are craving that input. There's no movement. Think of an immobile patient, but we've removed muscle activity. We've removed the ability to even do those small adjustments. And we wonder why their systems shut down, because we've stopped stimulating them. We've stopped that homeostatic regulation. And the more of their systems we do for them, the less stimuli there are for that normal homeostasis. Okay. So obviously with the SIRS, again, some of you are going to be like, oh, I know this. Different disciplines are not going to know it as well. So when you are thinking about being champions and moving forward as a multidisciplinary team, like physicians, nurses are probably going to know this better than PTs and OTs coming into the ICU who haven't worked in the ICU before. So obviously we go from a local inflammatory response with an infectious or pathological agent. When that is not enough to remove it, the body goes into a larger response. It pulls in the immune system or the immunoresponse. So we've got cytokines, we've got white blood cells. Those get released into the blood. If that's not enough to shut down that pathogen, then we go into a systemic reaction and this massive inflammatory response. Okay, so think about inflammation for a moment. PTs and OTs, you probably can relate to this specifically. What do we know about patients who have inflammatory conditions, fibromyalgia, rheumatoid arthritis, lupus, some of those big inflammatory problems? What happens to inflammatory cytokines when we don't move, when we rest? What happens to people's joints? They stiffen up, don't they? Rest, a long car ride for somebody with lupus or rheumatoid arthritis is horrible because they lose that flushing out of the cytokines. They build up in those inflamed joints, and they are more painful, more inflamed. So movement is good for inflammation. Rest allows those cytokines to actually build up and accumulate. It's not just the fluid in the lungs that accumulates. Rest allows all of those things to accumulate. Sometimes it's absolutely needed, but our question of the day is, when can we intervene and move even a little bit? Loss of gravity and exercise stimulus. So this comes from space research. This research comes from healthy astronauts who are peak athletes in the physical peak of their lives. Look what happens when they lose gravity stimulus. Does this look familiar to your patients? Right? Decreased stroke volume, increased heart rate, increased blood viscosity, increased central pressure, decreased functional residual capacity, increased risk of closure, VQ mismatch, we get shunting, we get decreased oxygenation, we get decreased blood flow in the central nervous system, we get decreased defense mechanisms in the antibody response in the immune system, the musculoskeletal loss, renal. This is healthy people without gravity, or healthy astronauts put on bed rest without any underlying illness. So this is some of the research that tells us that immobility itself and the horizontal position is an independent predictor of these things. Now you add critical illness on top of that, and you can see how quickly that storm builds up for our patients. So normal muscle activation. I want to talk about this a little bit because the ICU acquired weakness is such an important component and how fast the onset is. ICU acquired weakness is not the same as me not running. I'm going to be sore from our walk last night. Nancy took me for a walk last night. I don't have hills in Michigan. We walked up and down hills and I could feel it in my calves, right? That's normal disuse because I haven't used those muscles in that way. ICU acquired weakness is different. It is the organ dysfunction of the musculoskeletal system. And it's a breakdown of the neuromuscular junction. So normally, when our brain sends a signal to the muscles, we get that neural impulse to the T junction by our muscle cell. It releases calcium into the muscle cell, into the mitochondria. We have ATP. Again, you're like, oh my gosh, this is a lot of physiology. But I want to share this because of the importance of calcium. Without normal release of calcium, that muscle, the sarcomere, cannot contract, right? We cannot get a normal muscle contraction without, if we put too much calcium, too little calcium, we're not going to get a normal muscle contraction. And so what happens is that the muscle, in spite of that stimulus to contract, it can't. There's a breakdown between the nerve impulse and the ability of that muscle fiber to act on that impulse. Okay, so that's one of the mechanisms. The other mechanism that happens is that there are abnormalities in the sodium-calcium pump, in the balance of the salts, so that the resting potential of that muscle, it has to be at a very tight level for normal muscle contraction. And again, this is a lot of physiology, but there's going to be some, especially on the intern side intensivist. Why is this so important? What's the physiology behind it? The mitochondria itself, the mitochondria is what produces ATP. It's the powerhouse of the cell. Every single cell in our bodies has mitochondria. You're like, oh, nobody told us we were going back to cellular biology here. But this is important because the mitochondria, when it replicates the DNA for new muscle cells, we know in ICU-acquired weakness that it becomes dysfunctional. So the DNA, the new muscle fibers that are produced are weakened and disorganized with ICU-acquired weakness. It actually damages the biogenesis in that mitochondria. So the importance of maintaining that mechanical stimulus, this work that was done by Batt and team in 2017 and Lano Diaz 2012, they found even in the absence of sepsis and glucocorticoids. Now, a lot of the blame for this ICU-acquired weakness has been put on the sepsis, the cytokines, tumor necrosis factor alpha, IL-1, IL-6, the cytokines that are produced in sepsis has very often been blamed for the ICU-acquired weakness and the glucocorticoids that we give patients. But these studies showed even in the absence of those, that what they felt was there was no mechanical stimulus, no push, no pull, no weight bearing. And that has two effects. Our bones, our long bones, are the main storage units for calcium that's not used by the body, right? We know that calcium has to be so tightly regulated because it impacts nerve function, it impacts brain function and muscle function. So the calcium that is available is very, very tightly regulated, and what's not in the plasma and the blood is stored in our long bones, in our legs, primarily. What happens when we don't weight bear? When we're not weight bearing, that is that homeostatic signal that tells the body, I still need this much density, this much calcium in my bones. Astronauts that go to space demineralize. They come back with osteopenia and osteoporosis in their long bones because they don't have that compression, and so the body releases calcium into the bloodstream. Astronauts have kidney problems. Why? Because where does the calcium get excreted? How many of your patients are hypercalciuric? How many of them are excreting too much calcium in their urine, too much sodium, hypernatremia, within a couple of days of admission? So where is that coming from and what's the impact of it? When we're not weight bearing, the bones release calcium into the system. They have to be excreted. So we're asking the kidneys, oftentimes the kidneys are already hypoxic because we're dealing with hypoxia issues. Those glomerular, I had to speak this morning, that's a lack of oxygen. Anytime I can say it, just I'm too high up my oxygen, my brain's not getting enough oxygen. But those filtration units, we're asking them to work harder and filter more calcium, and we're not giving enough oxygen. So is it any wonder our kidneys are one of the first organs to shut down after lungs when we are immobile? So that's why I want to just share some of this physiology, because it makes sense. Neurophysiologically, it makes sense why our patients have so many of these problems, and horizontal position and immobility is a big piece of it. As we're going through the morning, I want you all to pay attention also to your cognitive ability to receive the information. We're just sitting, we're not laying down in bed. If we were all laying in bed during this conversation, how much would we be receiving of it? Probably not very much. So if you start to notice, and I'm going to be paying attention, I always do this whenever I'm teaching, if I start to see people kind of nodding off, I know it's because what I'm seeing, it's not because it's not really exciting. I know that. But just it's hard to stay attentive that long, right? We're going to get up and move. I did this in a presentation I did in Tokyo a few years ago. I had 500 Japanese doctors, and it was at the Tokyo ICU Rehabilitation Conference. And it was after lunch. I had the 2 o'clock presentation, which is the worst time to present. And so I'm up there, and of course my slides are in Japanese, and I said, I'm noticing people kind of nodding off. And all right, everybody, time to stand up. And I could see them all looking like this crazy American Scottish person. What the heck? And I'm like, no, everybody stand up. So I had them all do this, and they thought I was absolutely crazy. But it increases our cognitive receptive ability, right? When we're sitting, and that's just us sitting for a little bit. Think about our patients who are immobile, even without the sedatives that we add to that. Is it any wonder they have this cognitive fog, this decreased cognitive impairment? What happens when a patient's cognitive impairment, the worse their cognitive impairment and their judgment gets, what happens to their forest? That goes up, right? Their ability to work with us. The more their cognitive ability goes down, typically their anxiety will go up because they're less able to make sense of what's happening around them. What happens to call bell use when anxiety goes up? Nurses? What happens to call bell use? It goes through the roof, right? What's the impact of that? Do we start to get call bell fatigue? Do we start to screen it out? Our threshold for that patient's needs kind of goes up, doesn't it? Let's just be real. Let's talk about, we can talk about ideal status all we want. Let's talk about the real status. What really happens, because that's a barrier. Is it easier for a nurse to sedate the patient to up the midazolam a little bit and not have them sitting on the call bell? Let's just be honest. This happens in every ICU I've ever done some consulting. So it's not that we're bad nurses, that we want to do well, but there's lots of things that get in the way of that, right? We have to be real about it. We have to understand, why do we do that? Because there's a lot going on. How can we help each other to do it better?
And we're talking about the skeletal muscle, but smooth muscle has the same impact. So polyuria, a lot of the other bladder dysfunctions also have a direct impact on it and increase nurse work.
Right, and how many patients are impacted? How many of your patients are physically impacted? Probably a lot of them. How many are we giving stool softeners and enemas and elimination aids to? One. All of them, right? PTs and OTs. How many times have we been pooped on? Right? Why? Because we get them up. We stimulate peristalsis. Right? We stimulate peristalsis. So all those things we make jokes about in our professions, there's a real thing going on with our patients here. And moving is good. It supports every system in our body is impacted because we're gravitational. This is how we're designed to move, and we're dynamic. When we remove that, we are disabling, we are removing key functional stimuli for our patient's central nervous system to be able to retain their function. The other thing, and this was one of the interesting things in one of Kaylee's podcasts that jumped out at me, and it was a patient survivor who said, when you sedate me, you steal my fight. Let me be awake. I have a fight. I can fight this disease. But when you sedate me, you steal my fight. And that really hit me hard because now she's disorganized, she's disoriented, she doesn't know what's going on, and she's lost her own ability to fight that disease. So again, just so many impactful areas. So this again, this slide is normal athletes from space. The other thing I wanted to show here, I'm not going to go through, there's a lot of information, and if you're interested and want to go back and read all of this, you're going to get a copy of all of these slides, okay? But increased C-reactive protein, increased TNF-alpha, increased insulin resistance, increased oxidative stress, this pro-inflammatory state and selective myosin loss. This was really important from when I was looking at what happens with astronauts when they're put to bed rest, because that's preventable. If we can get our patients up and moving, we can prevent a great amount of this. So when Kaylee had shared, she was at the conference last week, and she said, you know, 90% of our ICU patients go home, walk out of our ICU and go home, 90%. She said she's had intensivists, doctors, pulmonologists, critical care docs challenge them and say, oh, you must not have high Apache scores. You must not have sick patients. Their Apache scores they have some of the sickest patients because they get sent to them. They've learned over the years that much of what we think is unavoidable is preventable. And it's just that shift in culture. So our vision, my vision for you here is that not tomorrow, but that becomes the goal, the vision for the ICU and that we're working towards, okay? What about gravity deprivation, immobility in the central nervous system in healthy people? We also know that in healthy people, there's decreased cerebral blood flow. The other thing that's very interesting is that they've done studies on the endothelial cells. And endothelial cells line all of our blood vessels, all of the microvasculature, our smooth muscle cells, the lining is endothelial cells, the blood-brain barrier is endothelial cells, and they are tightly regulated through the junctions between each cell. There should be a chemical mediator to say which cytokines, which proteins are allowed to pass through those channels and into the interstitial space in the brain matter, right? The blood-brain barrier is such an important element. One of the things we know with delirium is we have increased invasion through the blood-brain barrier, right? Of larger proteins, of inflammatory cytokines that normally should be kept out. What we know with astronauts is the junctions between those endothelial cells get looser and they become more porous when they are not subjected to gravity and when they're not moving and they're not, the mechanical push-pull stresses on those endothelial cell junctions is what keeps them functioning normally. So there's a connection there between what we see in the healthy people. Now, is that the only factor? Probably not. I'm sure the sepsis and all the things we talked about is part of it as well. But at least part of what we're dealing with is made worse by immobility. Okay, delirium and cognitive changes. We know that there are acute systemic inflammatory responses implicated. We know microvascular damage is implicated. We know early increase in C-reactive protein is part of the problem. Impaired autoregulation on day one. This was a study by Pfister in 2008. It's an older study, but I don't think anything has really changed since that study was done. So the longer that patient is delirious, that's directly associated, and Brenna, you've seen that in your patients. I would see it when I worked in outpatient physical therapy clinics, and I would see patients who'd been in the ICU, and this was really before I really started doing so much of the ICU work, but I look back now and go, now I understand. Physically, they recovered, but they would drive by their house. Cognitively, they forgot where they lived all their lives. They couldn't balance a checkbook. They couldn't do the daily functions, and it was the cognition that was disabling them. And nobody sees that, and that's really, really hard. Sometimes it's easier if they have a physical disability because people are more empathetic, I think, to physical disabilities than they are cognition. But the other thing is that it is 5 years. Margaret Arnold from Canada has done a lot of long-term studies and found that 5 years after discharge from the ICU, these problems are persisting for our patients. So often in healthcare, we've got our blinkers on to our window of when we see that patient. We have to realize that there's a whole life. And one of the patients, survivors we had last weekend at the Early Mobility Summit, shared with us that Peter did from the UK, shared that we often think when they leave our hospital and they've survived, that we ring the bells and they've made it. He said, that's just the starting beat for us. We've just made it over the starting line. All right, so.
Think of all the COVID celebrations we have. Yay!
Right, which is great.
It is great.
It's not to be undermined, but we're understanding that they have such a long road ahead of them. So this is a poster that you have. And again, a lot of this has a lot of information on it. I'm just going to pick a couple of things for today. That why not just wait for therapy to come? Why should nurses be engaged in the process of mobilizing patients? And why should we be empowering all team members and not always having therapy be the only ones mobilizing our patients? There's two reasons. One is that, and this is really little, but contractures begin, insulin resistance begins, plasma decrease in plasma volume. These start within 24 hours. Processes start to break down within 24 hours of immobility. People have asked me, well, doesn't that affect us when we go to bed and we've got the flu? Yeah, it does. How many of us, when we're in bed for a day, we get up and we're just like a little foggy, right? Or we bounce back very quickly. But think about our patients who may be existing at home just above the independent level. For many of our frequent flyer patients, they're coming in and the hospitalization, the ICU experience can just within one day put them below where they were sustaining up here, and now they're not. So really it takes all team members, and we should be looking at mobility from the very first day of admission.
When you're asleep, you're moving around, especially me. So people aren't necessarily sedated.
This is not a good color of the slide.
Yeah.
Is that better? You see a
Yeah,
little better? Yeah, note to self, go back and change the text color. Again, basically early mobility impacts all of these systems. It impacts all of the areas. We know it improves cognition. We know it improves peristalsis. We know it challenges a little bit of stroke volume, of lymphatic return. It challenges insulin resistance. It uses our muscles so that our muscles can actually use the insulin that is being produced, use the glucose that is being produced. So it impacts everything, and it makes us feel better, and it makes our patients and their families feel better. The one thing that I think is really important that patients have shared is the word hope. Even if it's just sitting up at the edge of the bed, being at eye level with the caregiver, with their doctor, with their nurse, therapist, family, there's an element that hope increases their fight, their psychological reserve to fight what they're dealing with. They suddenly see that there is a light at the end of the tunnel. So again, the Society of Critical Care Medicine tells us that none of the anti-delirium medications that we use are as effective as getting up and walking. The non-pharmacological interventions for delirium are far more effective than the medications, either to prevent it or to treat delirium. Any questions so far? I know I'm throwing a lot of information your way. You're like, oh, this is a lot first thing in the morning. The reason we don't do this after lunch. But again, I want us to just understand physiologically. It's not just that they're sleepy and they're a little sedated. All of these processes are happening when they're not moving. So again, the last slide with the circle showed all of these headings. And depression and cognition, just be more awake. We know that the pyramidal system in our brain, that's the system of the brain that deals with circadian rhythm, alertness, being awake. And we know that being upright relative to gravity stimulates that area of our brain much more so than being horizontal. And we all know this just from our own experience. You can be exhausted at work, you can go home, and as long as you're upright, you're good, right? You're able to focus on things, and you just sit on the couch for just a second. Right? I'm just going to lay down just for a second. What happens? How often are you like, oh my gosh, 20 minutes went by? When we get horizontal, that's a signal to the brain that it's rest time. Okay? So if we want our patients to remember what we're telling them, or to be cognitively alert, sit them up, stand them up, get them upright relative to gravity. We know in other areas of research that exercise decreases inflammation. We know it in cardiac, we know it with cancer patients, we know it with any kind of inflammatory condition. What is happening with my computer? Ugh, we're just going to say, it's what I felt like when I hear a noise in my car, I just turn up the radio. This might be why I have so many technology issues with my computer, just saying. Right. Exercise regulates mitochondrial function and biogenesis. This is really important. This is why This is the physiology of why getting people up and moving makes a difference to them. Point prevalence studies, this is around the world. We still see very low levels of, especially out of bed mobility. Some places are getting patients up to dangle, but they're not necessarily walking them, standing them. Remember the role of weight bearing and calcium? If we don't get weight bearing, we're missing that component. Okay, so people will often say, well, if they're sitting at the edge of the bed, isn't that good enough? It's better than lying. It's got some advantages. But if they were walking before, why are we settling for sitting here? It's sitting at the edge of bed functional, right? What do they need to be able to do to go home? They need to be able to get up and make themselves a snack. They need to be able to get up and go to the bathroom. They could sit over the edge of the bed 50 times a day. That's not going to help them retain their functional ability to go to the bathroom and stand up and transfer and walk. So in order to retain walking, we have to walk that. We are looking at different ways to, what's the optimal dosage of mobility? We don't know at this point. We do know from the COVID experience that little and often is better than one dose of mobility once a day. And I used to joke about this, but it's not really a joke, it's reality sometimes. What do we do? Typically, it's one supra-maximal effort for everybody, right? Okay, heave ho, here we go. We're going to start to sit at the edge of the bed. And 4 or 5 people and the patient and all the caregivers are sweating. The patient's like, what the heck is going on, right? They've got all these people around them. And they sit for a few minutes and then everybody's exhausted. What happens next? Put them back to bed, right? And where are they for the other 23 hours or 23 and a half hours of the day? In bed. So as good as it is to still do that, this is why it has to be multidisciplinary. So even if you have therapy seeing every single patient in the hospital, there's still that other 23 and a half hours. What are we doing there? How are we building mobility in? We're going to talk more about this later, but how can we do it in regular care? Meals. Can we get them out of bed for meals if they're eating anything orally? Just sitting them up frequently and then standing when we can. So again, we're going to look more at that, but we've got to do it more times a day. We know that functional level in the ICU matters in terms of readmission. We know that patients who are discharged without being confident to walk, if they came in walking like you and I, which some of our patients are our age, right? We see patients our age in the ICU, especially with COVID. And think about how many of them walk when they leave. With a walker, that could be us, like this. We know that when we are not confident walking, our fall risk at home goes up. What do those patients do when they go home? If they're not confident to walk, especially our elderly patients, they don't want to go to the bathroom, do they? Because they're worried about falling on the way to the bathroom. So what do they not do? They don't get up. But what do they not do so they don't have to get up? Don't drink. They don't drink because they don't want to have to go pee. So they become dehydrated. Those are a lot of our readmissions and our patients that come back with failure to thrive and falls at home and new issues that we see at home. So we're going to get into this a little bit more. We're going to talk about dosage. We do know from a lot of the early mobility studies, from systematic reviews, the facilities that waited 5 days to start, 4 to 5 days to start mobilizing, they missed the window. Those programs did not get the same outcomes as the programs that started mobility within the first 48 hours. So the term early means as soon as they are hemodynamically stable. We're going to talk about the parameters and practice that today, and we're going to go through, and so that all of you will know what are the parameters for safety, when is it safe to start moving them, okay?
A real life story around this is not an ICU patient, a patient that was from last week who requires dialysis. He's in his 40s. He hadn't walked in years, but he was able to sit upright. And he was in the hospital at our POD3. He needed the dialysis treatment. He could no longer tolerate sitting for 4 hours for the dialysis treatment because he hadn't been moved. He wasn't a PT and OT candidate. His level of function, they weren't looking to improve it, but we declined it so much that then he did become a PT and OT candidate, even to be able to get his dialysis. And his length of stay, the reason I heard about it is from the CNO of that hospital, because now he's there longer, he's no longer going home, and again, this is a young person that had dialysis for no reason, just day POD3 because we didn't give him a break. That was it.
And we have the tools. One of the things that's great that you have an advantage here, you have ceiling lifts in every single room. I was in an ICU a few weeks ago and they had one ceiling lift in the hospital. It's hard to coordinate that many people, but you've got the technology, you've got the machines to be able to do this. And so you're already at an advantage. This is doable without having 10 people teams to get those people up. Okay, so there's lots of different ways to mobilize. Yes, walking is great, and that's what we should be aspiring to. There's lots of other ways that we can move our patients in the course of their care. We've got to turn them over, right? How many of your patients do we inspect their skin? How often do we move them? We don't even ask them, can they turn over by themselves? We just turn them, right? We're missing an opportunity. We are depriving them an opportunity to move. If they're sitting up, we're listening to their lungs. Could we have them actively sit up to listen to their lungs? That's a mobility moment. That's an opportunity to have them use their muscles, use their brain, challenge lymphatics, challenge stroke volume, just in the act of having sit up and have them dangle to listen to their lungs instead of feet in the bed to listen to lungs. So there's lots of ways throughout the care that we're giving anyway that we might be able to build this in. So equipment, you know this stuff. I'm going to go through this pretty fast. We're going to be the next session, part 2 of this training. We're actually going to have this equipment. We're going to have
Contract issues, hopefully.
whatever we have. We're going to use whatever we have, and we're going to have fake patients, case scenarios. We're actually going to do it. We're going next part 2 of the training. It's going to be in the classrooms with some of the sims and all the lines, all the tubes. We're going to actually, as a multidisciplinary team, get them up and look at some of these things and how can we build this in throughout the day. So that's going to be fun. We just did that in Florida and it was pretty interesting. We've talked about this, the role of weight bearing. We've talked, there's more, Future, is that Future? I think there's an agency there. There's lots of studies on verticalization. Note to self, Margaret, change the color on these slides. Standing and pre-gauge, right, of the equipment that you have. We're going to look at ways to use some of the safe patient handling equipment to promote more mobility. So if you're doing, vitals, or if you're using a seated sling, can you use, if they're very, very weak, can you use a seated sling to sit them at the edge of the bed to take their vitals? That's a mobility activity, because remember, gravity is a constant force. So just sitting at the edge of the bed, maybe you can loosen the hanger bar just a little bit so that they have to do a little bit to hold themselves. They're still in the sling, but they have to work a little bit in there. There's lots of little things that we can do to build that in with things we're already doing for our patients. Just knowing what's happening when that's going on.
Well, no, like all of us,
They're nothing, right? That's right. And is it any wonder they have the problems that we see? That's right. Yeah. Anna.
Just how for today. I think a lot of times, we do a lot of open heart surgery, and I sort of people, especially you guys, who look at their 8 heads and we're like, hey, you gotta get up and get to the chair, and they're like, I just had open heart surgery, and they're like, how dare? Like,
I know.
They just look at their families and like, what do you mean you're getting them up? They just, and I think that's a big barrier too, because it's not the norm.
Right.
Right. It should be.
Should be.
People think, oh, my family members in the ICU, they're not moving. Yeah.
Is that a barrier? Patient and family expectations?
I think
it's a big barrier, isn't it? So,
even our patients that are awake and alert, because it's either that or they're tied down. And what do you mean they're tied down? Oh, it's just really fine line here.
Exactly.
We're trying to tow, and you're like, well, now we're going to get them up.
They were tied. Yeah.
So it's very, and I do think that a lot of times, like you said, the call bells and things, it's a lot easier sometimes to just give them a little extra dose of something. And the families, again, they're like, they seem uncomfortable. And you're like, well, they are.
That's right.
But the expectations that I think a lot of these people come into the ICU is like, this isn't going to be painless. This is not going to be fun. But these are the things we have to do. And unfortunately, the long-term effects can be worse than the, hey, we have to get up. I know you're hurting, but.
That's right.
So I think that's a big thing.
One of the survivors on that podcast, they actually got a legal document created, a do not sedate document, because they had had ARDS 3 times, and they had ARDS with sedation and ARDS without sedation. And their experience was, yeah, it doesn't feel good, but orient me to that. Help me with my pain, tell me why I'm uncomfortable, help me understand, give me my anti-anxiety medicine. She said, every single time I would rather be awake, and many of them said that too. It's much more traumatic to deal with post-traumatic stress and the hallucinations than it would have been to have, okay, you've got a breathing tube in to that point. And you're right, that culture, we know it is cultural in open heart.
And they don't understand the long term.
Right, right.
Especially because I feel like the family can be a big supporter. They can be big reasons why I don't want to do it. But if their family members are like, come on, you have to do it, you have to do it. It's not just some random nurse saying, we got to do this.
That's right. Kaylee has just started a podcast for families, which is really exciting, because I think that might be a resource that we can all use to show families, and it's all in family terminology that they can understand. So, Ken.
I think the importance of like the frequency of doing this. So like I know when I get patients up, they take 30, 45 minutes, like functionally get to a chair. And then I mean they're pretty light after that. Well, at some point they're getting back, but like that's not the end story. Like it should be good to like not only do the therapy, like getting up multiple times a day. And I know it takes a lot and it takes a lot of work to do it. And I know the patients are, but just like think about it, like, oh yeah, that was 1 hour out of the day. They're tired, but they can probably do it again with therapy with anybody else. So
Absolutely. Night shift, kind of did do some of that too, working that in one day.
Yeah, great. Morgan.
Yeah, I thought it was really interesting what you were talking about with regards to calcium and how that relates to like Icu part weakness. Like I know that like the muscle cells are obviously impacted, but to see like how it affects the kidneys and the bones and like really the entire every organ system. I think it's it gives us another push. Like okay, I'm not just affecting this person's muscles when I get them mobilizing, like I'm affecting everything.
You can engage your sepsis coordinators in this one.
For sure.
It really does have an impact.
Yeah, absolutely. Brenna.
It's a long-term cognitive deficit with occupational therapy. We want to get people back to working, back to living their lives, and they have these really severe cognitive deficits. And the things that people will tell me, I've seen like a few of the ICU patients come back on the other floors and they just like telling me all these stories about how they can't go back to work, how they're not able to play with their grandkids, and it's hard to hear that.
And we don't see it when we're in that window, right? And when they come back and tell us. And that's something to think about. We talked with your senior leadership when I was here in the exit interview for the gap analysis, was maybe bringing some of those patients back in to talk to the ICU staff about it. And feel free to sit if you want to, sit, stand, whatever you want. But that might help to make it real for people to understand that. So excellent. Dylan.
I think it's just interesting, like how it's reiterated that it affects every organ system of the body, and there's the cognitive effects, the CNS, peripheral neuropathy, and then just all of these critical organ systems are all involved in this.
Yeah. Okay. Amanda.
One would be like all the little steps that you could do almost immediately to make big changes. You don't have to make them walk on day one. You make them sit up, make them dangle, weight bear, decrease sedation.
What are your thoughts on RT treatments?
What's that?
What are your thoughts on your RT treatments and integrating some kind of mobility into them?
Like more like secretion mobility or something?
Yeah, and getting them more active. Like I know on the day of discharge, you guys will often walk and do a test. But what about some of that sooner?
No, absolutely. It's surprising to me how many times we get formal to discharge. And I'm like, when was the last time you were up out of bed?
Right. Well, and one of the things Chris Permy brought up last week when we were doing the ICU scenario, we were looking at the ventilator settings. That ventilator said, is this showing me the RSBI? And I'm like, wait a minute, I need to go back and do something. I don't know what that is. But that's the ratio, right, of the frequency to the tidal volume that tells you the prediction of successful extubation, right? And so what if we start that right away and start, that was new. I'm like, oh, if we get them up walking right away and see that, but they have to be awake to do that. So that's what we're going to talk about for the next, for this morning is how to do that. And I think we can impact so much of those. Maybe we don't send as many patients home And if we stand up, we know that in standing, the diaphragm goes down, right? Which is the best way to recruit those basal alveoli, isn't it? Right? Even in sitting, if you think of somebody now, if I'm sitting like this, my diaphragm, but how many of our patients sit like this? How many of them are like this? Where are the abdominal contents right now? They're right up against my diaphragm, aren't they? So can I do it? Can I engage my basal alveoli and expand my lower lobes? My rib cage just isn't going to expand because I'm kind of sitting on it, right? So once we get into this position, whether it's sitting in with a piece of equipment at the edge of the bed, even some of your non-powered stand aids, you don't have to stand, but you can sit and pull them up into an upright supported sitting. What if you just do some deep breaths there? Did you do that with a patient with a RAS of -2? Yeah, you can. It might wake them up a little bit more. Maybe you can lower the sedation when you get more up. So that's all the things that we're going to talk about. Great point. Awesome.
If we just did what was evidence-based, we wouldn't EPI.
If it was easy, everybody would be doing it, right? It's not easy to change practice, and I think we just have to be real with that. There'll be going to be barriers. We're going to meet resistance. We're going to meet things, family expectations, patient expectations, other nurses, other therapists, artists who maybe aren't as excited about this, and that's going to be the goal, is to make it manageable, stepwise, so that we change it over time and make it doable for people. Lisa.
When you said that when we sedate people, that we're taking away their ability to fight, that was pretty powerful and something that has in my mind as well. And then just like the effects of all the other things.
So let's talk about the basics of ICU mobility, right? And we're going to wake up, breathe, sit up, stand up, walk. That's it. We're done for today. You can all go back, right? That's what we're trying to do, ultimately, for every patient. We've already listened to this. So these are going to be some pictures and some videos from Kaylee Dayton's patients who are up and walking. And I think it's just good to see that this is doable and these patients are up and awake. Cognitively engaged. He's on the ventilator and he's working. Physically active, and again, all ages. And this is, like they say, at Latter-day Saints, 90% of their patients. There is a huge amount of inertia in healthcare, of comfort in the status quo. I read an article not that long ago that it takes 17 years in healthcare for new evidence, strong evidence, to become routine clinical practice.
And that's not new, that research is 40 years old. The 17-year number is 40 years old.
Right, it is. And have we really come very far with that? How can we actually change? And when I listened, the most impactful for me was listening to that podcast. I'm like, we've got to change this. We know too much to not challenge the status quo and to not change it. So this was a patient, trying to express unmet physical, emotional, and spiritual needs. So let's watch this video. This is one of their patients. How cool is that? She's having fun. How often are we having fun with our patients in the ICU, right? We do serious work, but if we can introduce an element of fun, again, it comes back to that hope. And these are people, it could be you or I. But the question is this what we see? Is this what we see? This is what the patients are seeing. These are pictures and art from patients who've gone through ICU delirium. And we've heard this, and again, Kaylee gave me permission. She said, share it wide and far. Now, this is a patient who was delirious. Again, look at the fun. And even in COVID, they found that even in COVID, their outcomes in their awake and walking ICU were far superior for their COVID patients in survival and in long COVID, because they got even those patients up by helping them move early and little and often throughout the day. So, and what about this? How meaningful is this? What's meaningful to our patients? How can we keep them as being human beings while they're with us? Right? Once we've got them intubated, we are supporting the lung organ, right? We're supporting the ventilation with the mechanical ventilator.
And just think about the rehabilitation impact of them doing normalized activity and all that as a OT perspective.
Absolutely. And even just family, how powerful would it be for family to see this and their loved one like, oh, they're not going to die. They're going to be okay. They're still Jim, they're still Johnny, they're still my husband, they're still my wife. We've talked about this already as the three things I always remember. We function in the upright position. Everything we do from the minute we're born, I have a little granddaughter who just learned to walk. And everything from the moment we are born is about getting upright, isn't it? Reaching that new goal, reaching that new shiny toy, expanding our experiences. And to be able to go home, patients must be able to stand up and get out of bed. They must be able to transfer. The best way to help them retain that function is to have them transfer while they're here. Training is very specific. We know this in rehab, and we know it in neurology and in stroke rehab, that no amount of strength training is going to make us better cardiovascular-wise. No amount of marathon training is going to help me lift weight. Training is specific to the task that we want to do. So if we want to retain ability to transfer, we must transfer. That's the only way to retain it. And then when someone is very sick, they fatigue very quickly. A little activity done several times a day is much better than 145-minute exercise. There's some studies that have been done on insulin resistance and glycemic index and lipid profile. People, office workers, not ICU patients, but office workers, who go to the gym and work out vigorously at the gym on the treadmill for 45 minutes in the morning and then sit at their desks all day. And then the other intervention group did not work out at the gym, and they got up every 1.5 hours for just a couple of minutes and walked around the office and then sat down. They found that postprandial glucose spikes and lipid regulation was much better in the people that did not work out in the morning but got up frequently throughout the day. So we have to think about what is the goal of our activity. If I want to build cardiovascular endurance, I have to go to the gym and run on the treadmill or go for a walk like we did last night. Right? If I want to build muscle strength, I have to lift weights. If I want to retain the ability to stand up out of a chair, I have to stand up out of a chair. And the neurophysiology is different depending. If I'm trying to stand up, especially from a low surface, it's not how many times in a row can my muscles contract. It's what percentage of those muscle fibers can I contract all at the same time with enough power to lift me up. It's a different function. So we must do those activities in order for our patients to retain that function.
And plus for overall caregiver safety, we do have 50 ways to leave your chair for our office workers, and we have a lot of programming on the internet about that to keep those people healthier. And since we've sent people home, it's even worse, because they don't even have to walk to their car, drive and walk into the office and go up down the stairs. So the weight gain and our one of the big complaints of those that are working at home is everyone's put on weight, and they're still exercising, they're still doing their normal routines, but they're moving so much less in that intermittent amount of time during the day. The bathroom at home's a lot closer to the bathroom in the office.
That's right.
It's been a big difference.
The other thing that ties into this is even when we're using the safe patient handling devices, that we're going to be learning and practicing across all disciplines. If I'm going to use a sit to stand because that patient's legs aren't weak enough or aren't strong enough to stand up on their own, it doesn't mean that patient just kind of hangs back and doesn't do anything. There's little things that we can do. Like one of the things I tell my patients is beat the machine. Try and beat it. Get your belly to the bar faster if you can, then the machine will go. Because that way, that first part, if they're in a low chair, they might need help with that first part, but they may be able to kick in their muscles and help with the last part, right? So just because they're using a device doesn't mean they're passive. And we're going to be learning how to use those devices more actively. Here's another little piece for the economic impact. This is sometimes our toolbox for our conversations with leadership, for getting equipment, for getting access to training. One pressure injury can increase the cost to care for that patient by $40,000. You probably are aware of that trend, right? You've got increased length of stay, you've got risk of MRSA, you've got risk of C. diff, you've got increased exposure, you've got wound care dressings, you've got pain. What, again, coming back to how much, if a patient gets a sacral pressure injury, how much more pain are they in? How much more anxiety? How much more are they on their call bell?
More medication.
More medication, all of those things. If we can prevent that by getting them up and moving, we're preventing so many of these other things that are very costly. One ventilator-associated pneumonia can increase the cost of care by over $50,000. That's what it costs the hospital to care for that patient, above and beyond the costs associated with that regular ICU or stay. So, according to the National Council on Aging, for each day your patient does not move their own muscles or challenge the systems of their body, it takes 1 week to recover. Some studies have said even longer than that. This is an easy one to remember. Each day of mobility is a week to try and recover from them. And if the patient is very frail, sometimes they don't recover. So we've already seen this in the last presentation. This is a little easier to see. And this is just, again, you're going to have all these slides. We've broken it down by complications by day, but then also complications of immobility by body system. Some people just process information differently, and so present it different ways. It might click with somebody that it didn't click in the other slide.
The mobility is medicine jobbing that went out in 2020, we might want to recycle those again. It has the 10 body systems. The more simplified format of this, but it gives a little physiology, it gives BMAT level, and based on BMAT level, what you can do to prevent these ill impacts. So it's a more operational form, and Brenna can disseminate to all of you that if you want to see it again. I don't know. We've had a lot of turnover, so it's probably time to
resurface that. That's right. The other thing, the other myth with education is we tell it once and we remember everything we do. Right? We learn. That is a myth. We know that when we sit in a classroom like this, we might retain about 10% of what is taught. If we have good audio visuals and interaction, we might retain up to 30% of what we learn. When we have interactive participatory methods in part of our training, it goes up to about 60%. And then when we teach others, we retain 90% of it. So that's why the model we are using for this program is that you're going to be the champions and then going to help teach others in your areas what you're learning here, because you will retain and you'll be able to be those experts that much better by teaching others. And not just teaching one class, but doing it several times throughout the course of the next couple of months. So, building a foundation. What is it? How do we operationalize it? So we've seen the why, we know what happens, but how do we actually do it? What does it look like? All patients will have a mobility goal and activity every single day from the moment they come in. So one of the things that we look at, we're going to be talking about with this, with the providers and the physicians and the admitting nurses, do we know what their baseline level is before they come to us? Do we have a good idea of what this person's normal mobility level is? Who are they? Are they active and mobile? Or do they come from a nursing home that we're bedbound? Because our expectation for discharge is going to be different, isn't it? So that should be on every single patient. And then what do we anticipate the discharge level of function to be? So this is, everybody's probably familiar with medication reconciliation, right? What medication were they on before they came in? What was the insult that happened to them, the injury or illness of why they're here? How have we had to adjust their medicines based on that insult? And then what do we expect their medications to be when they're discharged based on that? Functional reconciliation is the same thing. What, with function and mobility, what is their normal baseline? What did they come to us here for? If they were admitted with pneumonia, would we expect pneumonia on its own to change their mobility level at discharge? Or should that person, if they were walking before they came to us, regardless of age, and they come with only pneumonia, what should their discharge level of function be? Same, right? Walking, that's right. If they come to us with multiple trauma and hip fractures and pelvic fractures, we're going to do a reconciliation. If they come to us with a CBA, if it's just a TIA, what do we expect their discharge level of function to be? The same as admission. If they come with GI, they come for colonoscopy, what do we expect their discharge level of function to be? Right?
Hopefully they're not admitted to the stethoscope, but anyway.
Right, I know. But again, thinking about the medical condition, and would I expect that condition on its own to create a change in their mobility? This is where we start to have conversations between nurse-led mobility and therapist mobility, right? That rehabilitation, mobility is a part of that, but rehab is addressing specific structural and functional deficits. If the person comes in and maybe they're hyperkalemic and they come in and they're just off, or they're having some confusion and they're dehydrated, maybe they're just being admitted for some fluids. Would that person need a PT or an OT consult, or is that something that nurses could mobilize? In most cases, that should be nurse-led mobilization. When we empower nurses to own that piece of it and to understand that you're going to hear all the time, I don't have time. I don't have time, that's going to be the most common thing you're going to hear. But that's why I bring up the call bell issue. That's why I bring up the increased anxiety issue, the pressure injury issue. The deal is you're going to spend time one way or another. You can spend the time preventing the sequelae of immobility, or you can spend the time treating the problems caused by immobility. How difficult is it caring for a patient with a stage 3 pressure injury on their sacrum? It's not a fun experience for anybody, right? So, and it's very time consuming doing those dressings, and now it takes more time to change the bed. Now it takes more time to get the patient in a chair. It takes 2 people to get them up instead of 1. So I think if we can think about when we hear don't have time, go downstream a little bit and see how much time it's going to take if we don't get them up and we allow some of those bad things to happen. And everybody can be part of that conversation. I don't have time. When you hear that, trigger that conversation. Well, let's just think about that. Do we want to spend the time now? What's going to happen if we don't get to this one? What could happen? Daily mobility goals. So sometimes the daily mobility goal might be decreasing sedation so that they're awake enough to participate. Sometimes the daily mobility goal might be increasing sedation because they're agitated and they're combative. And so sometimes the daily mobility goal might be, we've got new neurological symptoms that we don't know what's causing them. We can't do mobility until we know that our safety criteria here. The goal today is to send them for a CT scan, reassess tomorrow. But it's always, what's the step, and then come back tomorrow. Daily mobility level. So how much help do they need to achieve their goal? So the goal is our goal to sit them up, stand them up, or walk them. If you've got somebody who's lost a lot of blood and their hemoglobin is 6.2, is your goal going to be walking up the hallway? Probably not. But could they maybe sit at the edge of the bed and watch their saturation and watch their perfusion and make sure that they're doing okay, even if it's for 1 minute? Is that reasonable medically for that patient? So these are the kinds of conversations that you're going to have on those team rounds on every single patient, every single day. What can we do to promote mobility? Right? Are they safe? What should the goal be? If all their hemodynamics are stable and they walked 2 days ago and their RAS is -2 and they're able to get up, let's walk them. But not every patient is appropriate for that. So that's where that medical complexity and their prior level of function, that helps us determine what's an appropriate level of mobility for this person today. And then the VMAT tells us how much help do they need to get there. So if this patient was walking yesterday and, or 2 days ago, and they're in the ICU, maybe they had open heart, or maybe something happened that they had a surgery and they had a bad reaction to the anesthetic, and they're just recovering, or they're bariatric and it's prophylactic that they're coming up to the ICU, and you sit them up at the edge of the bed and they've had a horrible night and they're a little dizzy and they're a little off. What do we do about that? Do we just leave them in bed because they're dizzy? Or do we say, what do we need to do medication-wise? Or do we use a sit-to-stand? Do we use a device? Because if they're a little bit off, a little bit dizzy, chances are we've got that gut feeling that, oh, this person could go down when we stand them up, right? So let's put a device on them, an ambulation harness or a power stand aid, because we've got kind of an idea that we know getting up is important. It might clear that dizziness, but we don't want them to fall. So, and then daily mobility activities. How can we build it into their daily care? And then daily, right? So the medical team is setting that goal that, and you do a lot of this already. So you already document the BMAT in the RN shift assessment, right? In your head to toe.
Oh, yeah, it's the bedside mobility assessment tool. So it's our standardized patient mobility assessment tool. We've been doing that, and then in the health record, but by something pharmacy knows a lot about. And so RNs do it, CNAs, and I know you guys don't have a lot of those on your unit, but they do them transporters, and then PT and OT speak in BMAT terminology, but they do a deeper dive.
So then mobility ambassadors or coaches, champions, communicating between nursing and therapy. Is this somebody that needs therapy to get them up and moving, or is it something that nursing can do? Now, initially when you start, you might do it all together until some of the nurses get a little bit more comfortable with it. If you've got nurses that are comfortable, we can start doing a little bit more. So again, gauging each individual person on your unit to see where their comfort level is going to be important. Can we get the person up to chair? Can we dangle them over this, have them sit dangling at the side of the bed? Can we use a commode or a toilet instead of a bedpan? One of the most impactful things I did, I was with a group of nurses assistants in our training because they always were very quick. This was on the acute care side more than the ICU, but it's relevant in the ICU too. It's easy to put a bedpan in. Most of them have a catheter in, right? But if we can get that catheter out, we know we're reducing UTIs and we're getting them functioning. We're less likely to fully void our bladder when we're horizontal. Generally speaking, the hole is at the bottom. When we stand up, anatomically, it is just more physiologically ready to void. But group of people, and it was the nurse assistants, we don't have time to get them home. We don't have time to get them to the toilet. Bedpan is the way we could do that. And I said, okay, at break time, I have a curtain here, there's a commode behind it. You don't need to go down to the bathroom, just go behind the curtain and the commode. When you go to the bathroom at break, just go behind the curtain. And of course, they're horrified. Patients are like us, right? We put them behind a curtain on a commode, and then we go, why do you need to go to the bathroom 5 minutes after I just put you on the commode? Well, because I didn't want to make a loud noise and have my roommate hear me. So think about the ideal is giving that patient the privacy of a wall or a door. In the ICU, that's not as prevalent. But again, if we can do it, if the patient can get up and walk, why not? Sitting versus standing, we've talked about that already. So preparing to mobilize a ventilated patient. Plan the event ahead of time. It does take some planning, especially in our complex patients. Discuss with the team what are the things we have to be careful of. If this person has some AFib, are we thinking about that ahead of time, right? What are the things that we're worried about? Review the safety criteria and the goal, and we're going to get into that in a moment, what the parameters are. Discuss with the patient. This is a piece that is so often missed in our ICU and even in our regular ward mobility. Asking the patient or their family for their input into it. Of course, if they're at a RAS of -3 or -2, and we've got to have them awake enough to be able to engage in that conversation. Timing to maximize the effectiveness of our medication. So if they're on bronchodilators or if they're on analgesics, can we time our mobility where those medications are maximally effective? And again, this is just the planning part of it. Determine a leader for the mobility. If the patient is intubated, normally the leader is whoever's caring for the airway, because that is the most important of all the tubes, lines, and drains, is that we keep that oxygen flowing. So again, make sure that they are identified before you do the mobility, and that everybody knows what they are responsible for when you're going to get that patient up. And then pre-plan what are going to be your termination criteria.
So you're watching the monitor, you're watching the vent. If that SpO2 drips down, you know, to 82%, have you decided beforehand, okay, if it dips down here, we stop, and anybody on the team can call it. If the patient seems to be getting really upset and anxious, decided beforehand, the patient can call it too. That's enough. Anybody on the team can call it. So it's worth having these laid out and plan it before you get up. The last thing we want is for something bad to happen with mobilizing people, especially when you're just starting out in your program. You want to have those early wins. So you're not going to take your sickest patient and get them up. You're going to start with those that are more stable on the slightly lower beats, you know, on the 5s, the 8s. You're not going to start with your peak of 12 or your peak of 10 and 70% O2. Start with your more stable patients who are a little bit more awake. Get people used to feeling comfortable sitting them up, managing the lines, the tubes, the drains, before you start with your sickest patients. So what equipment do you need? You do want to make sure you have an emergency airway available and an ambibag, right? Because even with somebody watching the airway, sometimes things happen. You want to have your portable O2 with you on the cart, especially if you're walking away from the bed. So make sure this is ready. Make sure you've got your portable monitors and your carts available. Does your portable cart have an arm for your tubing, for your ventilator tube? If not, who's watching that and making sure that they're stabilizing the airway? Do you have a method of securing the airway right now when you get patients up? Some people I work with they put a lanyard around the patient's neck that goes through the fork, you know, underneath that T-junction in the tubing, and then goes around the patient's neck so that it just supports that tubing. Others have just used, you know, really secured their anchor down so that they're comfortable and they're watching the grades of the tube to make sure it doesn't move. Do you have a method that you've used here to secure that?
We use the holster on the tubes so that whatever across the face, you just
that stays good. So
and then whoever's moving then should be idling the markers on the lips to ensure that it doesn't slide.
Yep. That's right. So generally we don't want that tubing to fall and the weight of the tubing. So how is that being supported? And that's one of your last minute checks before you get up. Okay, art line, tubing, we're going to go through the lines, tubes and drains a little bit as well. But have we got all those? Okay, check, 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 check. All right, let's go. So it does take some planning until you get a rhythm down. And then when you get new people that come in, we've got to go through that with them as well. So your safe patient handling equipment, right? You're making sure that you've got that in place. You've done your BMAT, you know what equipment you need. If in doubt, go more power. If it's right on the border, put a harness on them. It's better to not need it than to not have it and need it. Tilt table, tilt bed. So again, the different technologies, we don't need to go into all of this. And then do you have a recliner to sit them up for? It's all well and good to say, let's go to bed 3 times a day. Oh, we don't have a bedside chair. So make sure you've got that, and make sure you've got portable suction. Moving your patients will move their secretions. Expect to have increased sputum production when they get up and move. That's what we want. That's a good thing. Warn your patient. This is one thing that patients have asked me to tell everybody I ever talk to about mobility. Please tell us that it's going to feel like we're drowning. Please tell us whether I'm comatose, whether I'm awake. Tell me that when you put that suction, the anchor suction in me, it's going to feel like you can't breathe. Even if your patient is sedated, tell them that. Because so many patients have these hallucinations that they are drowning. And with the diaries, we've been able to relate that back to when they were suctioned. That in that moment, they can't breathe. And they have no control. They don't know what anybody's doing. So tell them what you're doing, even if you think that they told us they hear everything. Even in a deep sedation, coma, they hear. Their brain can't make sense of it, and it's the source of a lot of their hallucinations, but they hear everything.
And they know that where I told Margaret the story, my first job out of college was at Women's Hospital in Boston. I had a woman who was in the ICU. She had an aneurysm, 36 weeks pregnant, and they delivered the baby, and they had her pretty deeply sedated. And so I was going to do a PT, and her mom came to visit from India like day 4,
tone was worse. She had more mucoclonus. She had everything worse in her. And so second day, same thing. I just didn't get really good PT out of her. So I asked her husband, can you take mom for coffee when I do my next treatment? And we all kind of do those sort of things. And he just nodded right away and did. Anyway, she was discharged, went to rehab, and she came back for another procedure, and I treated her again. And she was alert at that time. And I asked her, hey, do you mind me asking you a personal question? And they requested that I treat them again, so I felt like I could answer it. And I said, what's your relationship like with your mother? And she said, you don't have to answer it. She goes, oh, terrible relationship. And she stressed me out. And she went through the thing, and she goes, why do you ask? I go, well, you have that same relationship with her when you're in a coma. Because it was like a huge difference for me. And as soon as she was at coffee, my treatment was fine again. So even that, it's amazing because it's my first shot at college. So, but yeah, I had no idea that was going on other than I suspected it because it's so obvious when she was there. So.
And even when it comes to delirium, like that, patients have said, when you go in for RT or resonance or anybody's coming in and changing numbers on the vent machine or changing anything on any of that equipment, those patients are lying there going, don't touch anything. That machine is keeping me alive. That freaks them out when somebody comes in and starts messing with settings because they know that that's what's between them and death. So they've asked us, tell me what you're doing, introduce me, tell me what you're doing and why. That will help prevent some of the delirium that our patients are suffering. Tell me, I'm your nurse, I'm your therapist, I'm going to be moving you, it's going to feel like this is why I'm doing it. Just talk to them like they're awake as you're going about doing whatever you're doing. And that alone, if we can share that with everybody that works with all of our patients, they have said that helps tremendously in orienting them to what's going on. So, lines and tubes. The green lines do not necessarily need an immediate response if they're pooled dislodged. Orange, which again, it didn't show up real well, it's more of a concern. It's a little bit more immediate. The red is life-threatening emergency. These are the lines we need to be paying most attention to. And if anyone disagrees with any of these, please let me know too. We don't want to pull out any lines, tubes, or veins, but I think it's important to know, especially therapists who come and work in the ICU, they're terrified. New PTs, new OTs are terrified of the ICU, right? If we want to get them more comfortable, and we're not prepared enough in school for all of it. So just helping identify lines, tubes, veins. We've got new people spending time in the ICU, just identifying, okay, this is the outline, this is the chest tube, this is the chest tube drain. You don't want that to go above. Just going through that, it seems so elementary for a nurse or a physician in the ICU, knowing that that's not second nature for people that are in the ICU. So the green lines, what are they? What do they look like? What do they do? Orange lines, so no supine during feedings and immediately following, avoid tension on the nasogastric tube, watch gate belt placement for pegs, and no blood pressure cuff on the PIP line, limb, no auxiliary crutches. So these are just some of the things that we share with therapists, nurses, doctors in the room. Anything you would add to this?
Assume we know nothing.
Assume we know nothing, yeah. Or Brenna or Trent or Morgan. Cap off any lines that we can. If we can cap off the nasogastric when we go to get them off, if there's anything we can cap and not have to have them attached, obviously do that. So the orange lines, and then the reds. So obviously we can risk of pneumothorax if we pull out that chest drain. That's a big no-no. Art line is a huge no-no. We want to keep the transducer at the level of the chest. That's something that, again, is important for reading those pressures right. If there's any femoral lines, if there's any cannulations, if they're on IVAP or any Swan-Ganz catheters, anything that's inserted through the femoral arteries, we've got to be obviously very, very aware and careful with in the femoral areas, ET tube, trachs, and obviously knowing the alarms on the vent. So that's another thing that when we're training new people, alarms freak patients out, they freak families out, and they freak new employees out, right? Because every alarm, especially therapists, they think they've killed their patient. It might just be a pressure alarm, they need to be suctioned. And they're freaking out, and they're like, I don't want to get that patient up, I don't want to do anything. We're just going to do passive range of motion today because I know I'm not going to set off any alarms. Have you ever seen it? Right? You've seen it. We're not doing what's best for the patient because of a fear that we can train around. All right, so which alarms do we really need to be careful of? If that's a pressure alarm because the ET tube has become disconnected, we need to know that. We need to know to go back and make sure we reconnect. That's a pretty big deal. So, lines, tubes, and drains. So placement and strategy, again, think about this as part of the pre-planning, right? Who's watching the art line? If they've got central lines, art lines, chest drains, it's not a bad idea to have an extra person.
Will be down for approximately 30 minutes, beginning 10 a.m.
So, who's watching all the videos? Who's watching the ET tube?
Will be down for approximately 30 minutes, beginning 10 a.m.
Can we just continue? Visualize your planned activity ahead of time. Think through the environment. Is there something in the way? Have you got the lines and tubes around the bed rail? How often has that happened? You go to get the patient up and the IV tubing is around the head rail on the other side of the bed, right? And suddenly it's pulling and their arms, well, what's wrong? Now they're bleeding at their IV side. We've all seen it if we've done even regular ward mobility. So thinking about that, organize and group the lines and tubes, ensure pressure gradients. Now again, some of you are thinking, well, this is a no-brainer. But these are things that new people coming into the ICU need to be taught. They're not all going to know this. Set up the environment pre-mobility, make sure that if you're going to sit them in a chair, where's the ventilator going to go? Where's the monitor going to go? Where is, if they're on a CRRT or if they're on ECMO, where's the stuff going to go relative? And are we going to turn clockwise or are we going to turn counterclockwise? Believe it, I mean, you're probably thinking that's a lot of detail, but it makes a difference. It can make a difference whether that mobility activity goes well or whether it's really bad and the new person that you've just convinced to get their patient up says, I'm never doing that again. Right? So planning that level of detail is really important when we're starting to get people comfortable with it, that we want those things to be early wins and call for help.
Like the Mobigo carts and some of those things that we have that can stay at the bedside and everything can be on, it can actually make that process so much easier. So as we're mobilizing patients more, if you start seeing that there's different equipment needs because of it, like those things that will decrease the time and the errors in doing this, start thinking about that and planning for that when you're looking at budgeting and things like that.
Is there some kind of checklist that you guys use to ensure?
There will be, yes, that's going to be part of this program, is having this pre-mobility checklist at the bedside that, okay, check, lines check, outline check, have we checked their SpO2, have we checked their mean arterial pressure, are they within the parameters? What are we going to do? It is in the handout, so we're going to, good call, because that's where we're going next. This is doing the mobility. So between today and the next training, we're actually going to get into the what does it look and feel like and actually doing it. Today we're going to be actually doing RAS screens and doing CAM ICU on each other. We're going to do it, we're going to see it, we're going to do it with Nancy as the patient, and then we're going to be doing it on each other. So you're going to be the patient, I'm going to give you different papers, and you are going to play that role of the agitated or the sedated patient, and then you're also going to be screening it. So this is the algorithm that comes from AHRQ. You'll see different variations on this. You as an organization can take either this one or you can tweak it. We're going to meet with doctors later today. But the inclusion criteria for mobility are, number one, that the patient opens their eyes to some kind of verbal stimulation. If they do not, then we need to ask, are they medically induced sedation? If the answer is yes, consider a spontaneous waking trial, unless they meet the criteria for deep sedation. We're going to talk about that. If not, is there some primary neurological etiology going on? Have they had a traumatic brain injury? Have they got something else going on that's undiagnosed? So we need to then work on that, figure out what's going on, and then reassess tomorrow. You're going to see here all over it, reassess tomorrow. It didn't work today, let's come back to it either next shift or the next day. So if they can open their mouth, what are some of the inclusion criteria? Respiratory. And again, do any of these criteria make anyone nervous to get a patient up and moving? If their fraction of inspired oxygen is less than 60%, is everybody in this room comfortable with getting a patient up on 60% FiO2? What about peak of 10? Is everybody comfortable with getting a patient up with a peak of 10? You're going to have some people that aren't comfortable. You know, some people who say, if this is what my patient is, they're too sick. Right? Don't you realize they're on a peak of 10 and they're on 60%? Yeah. Yeah, but we're going to mobilize them to try and get that down. I had a doctor in I still do a little bit of per diem work at my own hospital in Michigan. When I was working in the ICU, this was a couple of years ago, the pulmonologist said, Margaret, I want you to get this person up. They have the tilt thing that you have. And I'm like, doctor, they are on a peak of 16 and 100% oxygen. That is outside all of the safety parameters for getting a patient up that I have ever read. And he's like, Margaret, they're dying. We've tried everything. They're not responding to anything else. I'm like, okay, you're going to come with me. You're going to stand right here, and I want to see it in writing. Exactly. We stood him up, and when he reached 60 degrees on that tilt bed, his diaphragm dropped, and they suctioned. The RT was there, suctioned all this really thick plugs of mucus, because that change in pressure freed up a lot of the stuff. We were able to get his peak down right afterwards to 12, and he was maintaining his O2 sats and his ABGs on. So again, it could have gone the other way, right? We were dealing with sick patients, and we have to be cognizant of that. We are dealing with very sick patients. That's why we have the criteria. No hypoxemia, SpO2 greater than 88%. How many of you COVID patients were at a baseline of like 78? Right? So again, this is the safety criteria, but the medical team is going to do it case by case. Right? You might have somebody with chronic COPD, and then their baseline oxygenation might be in the low 80s or mid 80s. So you've got to look at that on your case by case. No metabolic acidosis. Circulatory, you want to make sure that there's no escalating titration of pressors. There are some facilities I've worked with, if the patient's on any pressors at all, they won't get the patient up, because don't you realize they're on pressors? Yeah? Well, the pressors doing their job? Is their mean arterial pressure stable on this dose? Okay. The SCCM guidelines are, if they've been stable on a dose for 2 hours, we can get them up, unless you've been having to escalate, right? If they've been stable and they're not escalating, then the SCC, but again, think about who you're going to start hitting up with, especially in people that are a little bit nervous. You might have people who are on lower doses of pressors. Let's not scare people out of the gate. But it's important to know what has been shown to be safe in the literature. And these parameters have been tested in over 15,000 patients to be safe, with a less than 1% adverse. So,
can I ask a question about this?
Yes.
So, it looks like this is the inclusion criteria, but oftentimes once you start moving people, even around in the bed or sitting up or whatever, at least from a respiratory perspective, like all of those numbers get worse, particularly with COVID. We saw that when people were laying still or paralyzed or whatnot, those were all fine. But then so I'm confused about how, if they meet this criteria, suddenly they streamline into the early mobility protocol without, like, I think that's our barrier. I think everybody here is into it, everybody's interested, but it often falls apart because, you know, when we turn the sedation off or whatever, or move the person to the side, we see that the SAT gets worse. So,
right. So you've also got termination criteria. So if they're at a SAT of 95, right, on 60% O2, and you sit them up over the side of the bed, sometimes their O2 SAT does drop to 85, 86, 87. Sometimes they start using accessory muscles to breathe with, right? They're anxious. The criteria is, the recommended practice is give them a second, right? Sometimes teach them, talk them through relaxing, talk them through, okay, just relax, take a slightly deeper breath. Often their O2 SAT will come back up. It's a transient change in response to that change of position. Because if you think about it, when we move them, think about those homeostatic responses and those stimuli for a training response. Part of what we're doing here is evaluating their ability to adapt to a stimulus. So for example, you set them up, if they haven't been up for a couple of days, their lymphatic, their venous systems might be really sluggish. Their stroke volume might take a second to react to that change in fluid, because the fluid is immediately going to go to their legs because of gravity when you sit them up on the side of the bed. If that response is a little sluggish, their blood pressure may drop initially when you do that, right? Because you've just changed the dynamics, and the baroreceptors, which normally are highly responsive to a change in fluid dynamics, they've gotten a little sluggish because we haven't stimulated them. So what the SCCM says is a change in 20% in blood pressure, up or down. Usually it's the lower levels. A rise in blood pressure isn't usually as concerning as a drop, because a drop is your perfusion to your brain and your other organs, right? Your ability to move. So you're absolutely right. We've got to understand what is our termination criteria. If their respirations go up to, 35 per minute, if you can talk them for a second or two for a minute, okay, slow it down, relax. Very often, you can actually bring them back down. And so that transient change has resulted in an adaptive response, which has recruited more alveoli, which has created that stimulus maybe for more hemoglobin production in the red blood cells, in the bone marrow. Maybe it is created, what we think about training response, but we have to grade it according to what that patient is. If the patient is barely hanging on to life, we don't want a big training response. We can anticipate their ability to adapt to a change in position is going to be compromised, right? So that's part of learning and getting comfortable with a change in blood pressure, a change in heart rate. How big of a change do we need to be worried about? If the patient is in a new antiarrhythmic agent because they've been going into AFib, you know what, that's not my patient I'm walking down the hall today. If I'm starting, I may just start doing a little bit of movement around the bed, make sure that that AFib, that new antiarrhythmic drug is working and that their heart rhythm remains stable with small movements before we do the big movements. Right? Does that answer your question?
Kind of. I mean, I think it's extremely patient dependent, and I think that, yeah.
This is just the criteria to even be ready to think about mobilizing.
Sure.
If they don't meet these, that's your patient that we have to, medically they need some more work to get them ready. Now, again, this is just what has been shown to be safe, but we have those termination criteria as well. If it's more than...
And then the one other thing is where they have to do the spontaneous awakening trial, and they pass that, then they go to early mobility. Is it that plus meeting the inclusion criteria?
Yes.
Okay.
Yes, exactly. And that's what we're going to talk about today is what are the criteria? Because people often mix up the criteria for a spontaneous awakening trial and a spontaneous breathing trial and early mobility. So that's what we're going to practice going over today and understanding the difference of what are the criteria for spontaneous awakening trial and what's a pass, what's a fail. It's going to take practice to get everybody comfortable with that. We're going to start to where everybody's comfortable with these parameters. And if they're not comfortable here, when we meet with the doctor group, and for you also, maybe we start with a FiO2 of 50%. We start with a more conservative range of numbers. That's perfectly okay. We just start somewhere, right? And what can we all agree on that we're going to start with? What we're doing here is we're taking away the gut feel of my patient's too sick and replacing it with evidence. And setting some parameters. And if there's any concern, we stop. If there's any concern, we stop, we reevaluate, we come back to it tomorrow. So in here, you also see what is an SAT failure, right? Persistence, anxiety, or agitation. And Brenna, I'm going to have you talk through this when we get to that point of waking people up. How do you deal with that? Respiratory rate more than 35 per minute. Now the AHRQ and the SCCM will say give the patient 5 minutes, even if their respiratory rate is more than 35 per minute. You may say, we're not comfortable with that, we're going to go 25 per minute, or 3 minutes. That's okay. Start somewhere, right, and then build from it. So these numbers that I'm putting up here, absolutely modifiable for our starting point, but it's important that we can all agree on what those numbers are going to be, all right? And your input is great, because what you're feeling in response to these numbers, everybody else is going to feel the same way, right? So we have to start where people are confident and comfortable going. And then the SpO2 sustained less than 88%. For an SAT failure, we're over on the right. SBT failure, so spontaneous breathing rate failure, respiratory distress, acute cardiac arrhythmia, mental status change. Those are the criteria for, okay, we have to continue to support ventilation for a little bit longer. And we're always discussing the risks and benefits along the way. So we talked about this already, the checklist. So well, now we're going to jump into a little bit more is the agitation, the sedation. That's the first step. The inclusion criteria and the parameters we'll get to later, but for today, for the rest of today, we're going to focus on screening RAS and screening for delirium with our patients. And we've talked a little bit about the causes already. This is the RAS. Has everybody done RAS scores before? Okay. The RAS is in front of you right here, and it's in the handout, and we're going to make printouts of this. But basically, you're going to observe the patient, and one of the things we found on the gap analysis was that there was a difference, there was a discrepancy between what nurses were documenting as the RAS score, and then when therapy would go and screen the patient for RAS, there was a discrepancy between the two disciplines in what was the true RAS. So one of the things we have decided to start with is making sure everybody rates the same way, and that everybody can recognize what the different levels are. So today we're going to practice that, and also doing the TMICU screening for delirium. Okay, so a RAS of, it goes from +4 combative to -5 comatose. Alert and calm is 0. +1 is a little bit restless, anxious and restless, but movements are not aggressive or violent. A RAS of +2, the patient is agitated, visibly agitated. They are making frequent non-purposeful movements. I describe this as writhing, right? Moving arms, legs, just clearly uncomfortable, more than just twitching and anxious, clearly moving around, and they may have ventilator synchrony with a RAS of +2. If they're very agitated at a +3, they're pulling on their tubes, they're pulling Foley's, they're trying to grab things, they're more aggressive, and there's potential for self-harm at a +3. And this is the key thing that they say here is trying to pull out tubes at a +3. And then a +4, they are overtly combative, and they are trying to hurt. They're throwing punches, they are a danger to themselves and to the staff that work with them. So that's on the plus side of the agitation scale, but the X is the sedation side, -1, and most patients, there's only about 5% of patients who are more on the agitated side. Most patients are on the more drowsy sedated side. So -1, this is your ideal patient, isn't it? They don't complain, they don't ask for anything, they don't ring the call bell, but they're lightly sedated, they're drowsy. They can remain awake, and the important thing with the -1, they make eye contact with you for more than 10 seconds. So they can be awake in response to voice and make eye contact for more than 10 seconds. If they can make eye contact a little bit, but less than 10 seconds, they are a RAS of -2. All right. -3, they're moderately sedated, there's no eye contact, but they can move in response to voice. So -1, 2, and 3, they respond to your voice, the auditory stimulus. -1, more than 10 seconds. -2, less than 10 seconds. -3, they move but don't make eye contact. Their eyes might be rolling, they might be closed, but they will move in response, turn your head, whatever, in response to your voice. A -4 is no response to voice. But if you do a scapular pinch or a sternal rub, you physically stimulate them, there is a movement in response to a physical stimulus. Okay, so that's the difference between a moderate and a deep sedation. The -3, they respond to your voice.
It's a team that
It's what would normally be uncomfortable for people. Like if somebody rubs you right on your collarbone, oh, don't do that, please. Right? We're looking to get that kind of response, that kind of a shift of movement away from that. And if there's no movement, then they're any questions about this? Fran, I'm going to just ask you for a moment because I know you've seen some differences. What was the biggest discrepancy that you saw that we talked about in our gap analysis?
I feel like most of the time, I think when I go into a room and I'm expecting, I see that they're like a -1 or -2, and I go in and they're like really not responding to me at all. They won't open their eyes, they won't respond to my voice, and so then it's really hard to do any kind of therapy. I can do like sensory stuff, but like it's not really going to be able to get them to follow any commands, so they're more overstated than unexpected.
Right, and I think a lot of the time, and I find this everywhere, that a lot of times in the nursing note, it'll say -1, -2, they're at target RAS, but actually they're more sedated than that. So that's one of the discrepancies. And when we looked at the CAM ICU scores, and we looked at the percentage of unable to assess the CAM ICU, what was there, 70% of them that said unable to assess. Even somebody on a -2 or a -3, we should be able to do to screen them for delirium. We're going to walk through what that looks like. So if they're -1, if the sedation is at the right level for them, we should still be able to assess CAM ICU. So one of the things we're going to be looking at early with data is, are we seeing that percentage of unable to assess go down? That's going to be the first indicator that we're seeing people are getting this right, is we're going to see fewer unable to assesses on the camera, the delirium screen. Okay? So let's watch the video of what this looks like.
Tim, hello. Hi. How are you doing today? You doing okay? We're going to get you up and try and get you out of bed. Try and get you up on your feet. I'm Margaret. I'm your physical therapist. All right. You ready to go? Give me a thumbs up. Hi, Tim. Hello. Hi, my name's Margaret. I'm your physical therapist. Tim, can you open your eyes? Hi. We're going to get you out of bed today, okay? You ready to get up? Can you keep your eyes open for me, Tim? Hi. Keep your eyes open. Your family's going to be coming in later to see you. Keep your eyes open if you can for me. Tim, hi there. It's Margaret. I'm from physical therapy. Tim, can you open your eyes? Hello. Tim, I'm your physical therapist. I'm going to be getting you up today. We're going to try sitting up. We're going to try sitting up, Tim, and get you moving, okay? My name's Margaret. Hello. Hi, Tim. It's Margaret from physical therapy. Tim, can you open your eyes for me? Hi, Tim. Hello. Hello. There you are. Hi, Tim. Hello. Tim, it's Margaret from physical therapy. Can you open your eyes for me, Tim? Hello, hello. Tim, it's Margaret here from yesterday. Can you open your eyes for me, Tim?
to get them involved in doing something that you can then use for training moving forward. And people actually have fun being that patient, and doing a project like that is a great way for people to learn as well. So again, it's fairly straightforward, but people still get it wrong. So we're going to be practicing, and from here on, today forward, every single patient you see, do that RAS score with them. Teach others about it. You know, yes, this is champion training, there's going to be all staff training, but why wait? Why wouldn't we go back to the unit and start to talk to people? RAS is something we should be doing anyway. When we talked about data, this was one of those just do it. So let's talk now about delirium, because RAS is part of the delirium score. And that's the PAM-ICU that you have. You've got the RAS on one side and delirium on the other side, the PAM-ICU. Should have on one of these handouts. Oh, there you go. Okay. So there are 4 features that are classic of delirium. The first is acute and fluctuating mental status. The first 2 they must have to qualify for a CAM positive: inattention and acute or fluctuating change. So if they've been stable and they're at the same level, maybe they've been sedated at a -1 and they're still at a -1, there's no change, they're on medication, that's not an acute change in mental function. But something seems different, something feels off, that's an acute change in mental function or mental status. Or yesterday they were answering questions appropriately, and today they're saying some off the wall stuff that's an acute change. Different from dementia. Dementia is a progressive neurological worsening of mental function. The difference here, sometimes patients have dementia with acute delirium superimposed on it. Those are very challenging to do, but that fluctuating status and then the inattention. And then they must have both of those plus one of the other 2 features, which are altered consciousness, which is your RAS, anything other than a 0, and disorganized thinking. So they must, for delirium to be positive, they must have an acute change or fluctuating status plus inattention. Both of those plus either altered consciousness or disorganized thinking. So we're going to go through that. We already talked about some of the causes and some of the harms from delirium. These are just in your handout for the mechanisms, if anybody is very interested in the mechanisms. And we talked about this already, but it's just in this slide here that they feel they've been taken hostage, they feel they've been taken. Why do you think they might have felt that they've been kidnapped? Or restraints, neuroparalytics and restraints. I can't move, my brain says I gotta run away. I've got a patient who talked to me and said, I was peeling away my chest tube dressings and peeling away all my dressings because in my mind, those were the things that my hostages were keeping me. So every time a doctor would come in, I would stop. But as soon as the doctor or nurse would leave, they'd be peeling away the dressing for their chest drain because that's how they were going to free themselves. Because that's what was holding them here. We've had people feel like they've been overseas in just all these awful kidnap, hostage situations. People thinking they've been raped. Why do you think they think they've been raped? Always. Yeah. Huge numbers of patients feel like they've been sexually violated, right? Because their brain is trying to make sense. One of the other things is we've suggested, let's play their favorite music. Some of the patients have said that ruined that song forever for me. I used to like that music, but now I associate it as a PTSD response. I had another one say that somebody well-meaningly put on the Nature Channel for me on TV because they thought that that would be relaxing for me. Well, suddenly in their brain, they had these monkeys attacking them, and their hallucinations were all about being attacked by animals. And they were coming to get them because they couldn't move. They had all these animals and they couldn't move to run away. Think about that. So again, it's just about understanding what we're doing and what the patients are doing to try and their brains are trying to make sense of it. patients who said that they dreamt that they were drowned and they were having babies underwater. And these are not dreams. These are real to the patients. And this is what causes them their PTSD. And all their babies were floating away and they couldn't catch their babies. Totally irrational and unorganized, but the emotional and the trauma to them was real, as if that were actually happening in real life. So again, if we can change this and wake them up and get them, and those were the -3s, -4s, even some of the -2s were feeling some of those effects. 3 types, there's the hypoactive is the most common. Hyperactive is, only a small percentage, and some go between both, and we've seen that too. Again, just some stats here, why should we care? I think we've covered that already, but this gives you some of the stats on the long-term outcomes for patients with delirium and what the mortality is for them, as well as long-term cognitive changes. So, some of the things we can do to prevent and treat it, like Brianna said, repeat reorientation. Tell them every single day where they are. Tell them you're in the hospital, this is your breathing tube, you know that you're going to feel all these lines, this is what they're for. Don't expect them to remember it. Keep telling them over. Tell them who you are, what you're doing, and why you're doing it, even if they're comatose. They hear everything. Make sure that we're waking them up, opening the curtains during the day. Even better than us opening the curtains would be what? Have them come. If it's possible, have that be their mobility activity. Let's go open the blinds today. The action of opening the blind is so much more functional for them than us doing it for them. If that's appropriate. Not every patient is going to be appropriate for. So these are some of the ways we can build it in. Making sure they have their vision, their glasses, their hearing. So often we forget about those details. But if they can't hear, they've got sensory deprivation, right? And we've already isolated them. We've already tied them down. We've drugged them. We've disoriented them day and night. That's what they do to prisoners, to disorient them. And that's a form of torture in prisoner of war camps. Isolation, disoriented day and night, don't let them move, tie them up, drug them, adequate hydration. Make sure they're not dehydrated. That's really important as well. This is just another list from this article that was in 2020. That was just a recent publication. It just reaffirms what we're already doing. That could be a checklist that you put together for everybody as part of the training as well. There's a slide here, but again, a good thing for everybody to know. All right, so let's look at the CAM ICU now. They must have both feature 1 and feature 2, and one of the others in order to meet CAM ICU positive. The biggest thing we see is the inattention, right? That's usually the differentiator, because if they've had a change in mental status, usually they're already meeting feature 3. Let's go through this and start with a change in mental status. My patient seems off. If they seem perfectly normal and they are just the way they were, they're alert and calm and they're responding, your CAM ICU is done. It's done. You assessed it, they're responding normally, there's been no change in mental status. Remember, in order to be CAM positive, they must have both of those first 2 features. So, we don't need to go through the rest of it if they are the same as they've been and they're responding. But if not, if there's been a change, then we go to the inattention. We always use the same letters. That way people are not confused. Save a heart with 2 A's instead of the HEA. And what the patient does is they squeeze your hand on every letter A. Right? The important thing is we've got to make sure, first of all, they can squeeze our hand. So if they don't have the strength to squeeze our hand and we don't test that first, they could be a false positive because they might know, but they just can't do it. There is a picture alternative for this, where you can shake your head or use something other than squeezing if they're too weak. But you talk it through slowly at a voice that it rises above. You're not yelling, but enough that they can hear above the din of the ICU. And you say each letter 3 seconds apart. So you got to give them a little time to process, right? Slow processing is different from inattention. So basically, you're going to say, squeeze my hand every time you hear the letter A. And then it's X, A, B. One of the mistakes people make is they go through it too fast and they get a false positive, right? Because the patient is still, they're still back on the S and you're on the V already. So making sure that you standardize that it's 3 seconds. And an error is if they squeeze on a non-A or they miss a squeeze on an A. If they have more than 2 errors, that is a positive for inattention. All right, so most often, you've already done your CAM ICU by this time. Most often, if there's a change in fluctuating mental status and they have inattention, when you get to number 3, you've probably seen a change in RAS. Not necessarily. There are some patients who can have a RAS of 0 and still have disorganized thinking. That's rare, but it's possible. So if they're positive, they've got the first 2, they missed a couple of letters, you go on to altered level of consciousness. If they're anything other than 0 for RAS, then they're CAM ICU positive. But maybe they are a 0, it's a rare case. Then you look for disorganized thinking. And these are questions that, you know, does a stone float on water? Are there fish in the sea? And you always ask the same question. Does 1 pound weigh more than 2 pounds? Obviously, we should know the answer. And then there's 4 questions, 1 command. So there's 5 things in the disorganized thinking. If they get more than 1, they're allowed 1 of them wrong. But if they get more than 1 wrong, then it's a CAM positive. All right. So fluctuating mental status, inattention are the most important ones. And then is the RAS anything other than 0? And is there disorganized? Any questions about that? No, it's pretty straightforward. It's not as hard. A lot of people seem to think CAM is hard to do. Once you start doing it, it's really not difficult. So is there a change from baseline? How do you determine it? Pre-hospital status, daily mental status. What if the patient is on sedation? Can you tell if there's a change in mental status if they're on sedation? If they're a -1, that's easier. If they're a -2, it's a little tougher. The deeper sedation, it's harder to assess, right? So if all of your patients are on -3 or -4 of RAS, we're going to see unable to assess CAM. What should be the action? Decrease the sedation, right? Maybe we're using too much sedation, which feeds into your goal. We can reduce the sedation. We're going to, again, the primary reason should be to decrease cost. The primary reason is to make it better for the patient outcomes, but a byproduct is decrease cost. Yeah. Inattention, again, that's this is the one that seems to differentiate most of your patients. It's that inattention and inability to squeeze your hand appropriately. What's the difference between feature 1 and feature 3? The target RAS and feature 1 is just if there's a change, they just seem off. That can be an alert and oriented patient who makes inappropriate comments, right? It can be somebody who's responding normally, but says, you know, I saw my mom last night and they're 95 years old. My mom visited me last night. They're alert and oriented, apparently. They're calm. Their RAS is negative, is 0, but they're seeing them off the wall.
We're going to demonstrate the CAM ICU, and the trigger to do a CAM ICU is that there is some change in mental status in the last 24 hours or from baseline. So something just seems off with your patient. If everything seems normal and they are responding appropriately, there is no acute and fluctuating change, then they're automatically CAM ICU negative. But if there's been a fluctuation or a change, that's one of the cardinal features. The second one is inattention. And we're going to check for the ability to recognize the letter A. We're going to use the acronym SAVE A HEART with 2 A's in the word heart. And we're going to ask the patient to squeeze your hand just on the letters A. If they make a mistake, either by squeezing on a non-A or by missing an A, that is counted as an error, and they can make 2 errors. If they make more than 2 errors, then that is a positive finding for inattention. So let's see what that looks like. Hi, Tim. How are you doing today? Tim, can you squeeze my hand for me? Squeeze my hand. Can you squeeze it? Good. I'm going to say some letters, and I want you to squeeze my hand when you hear the letter A. You ready? Okay. S, A, V, E, A, H, A, R, T. Okay. So you saw that Tim made one error. He missed one of the A's. That is still a negative for inattention. The other part of delirium that we look for is disorganized thinking. And there are 4 questions and 1 command. So I'm going to ask Tim the questions, and they're always the same questions. Tim, does a stone float on water? No, that is right. Is 1 pound more than 2 pounds? That's right. Are there fish in the sea? Can you use a hammer to pound a nail? Okay. And lastly, Tim, can you hold up this many fingers with this hand? Good. Can you do the same on the other side? Excellent. Okay. If the patient is unable to lift 1 arm, you can ask them to add 1 finger. Tim, can you hold up this many fingers on this side? Good. Can you add 1 more finger? Excellent. If they get all the questions right or they get 1 wrong, it is CAM ICU negative. If they make more than 1 error in the disorganized thinking, so either they answer 1 question wrong and they get a command wrong, or they get 2 questions wrong, that is positive test for disorganized thinking. So for a CAM ICU to be positive, they must have a change in mental status that is acute and fluctuating, and they must have inattention, which is more than 2 errors on the Save a Heart. They also must have 1 of the other features of delirium, which is disorganized thinking or altered consciousness. So if they've got inattention and a change in mental status, plus a RAS score anything other than 0, that is CAM ICU positive. Or if they have a change in mental status, inattention, and disorganized thinking, that is a CAM ICU positive.
You guys got that really quickly. You know, he is getting everybody measuring exactly the same way and scoring it. So is it feasible, once you leave this classroom today, to start working with your co-workers and even, but first of all, doing it on your own? Every time you go out a couple of times, once a shift for sure, but if you notice anything different, notice any off-the-wall comments or anything that happens, that's your first key that something's going on with the shift, something's changed, something's different. Because remember, if they're the same, if they're at normal status for them, you don't just do it.
What's your instinct as to why there was discrepancy between the rehab assessment and nursing? Okay, because it's really good.
And they might be reducing the station because I think this is honestly like the definition is that it's fluctuating. Yeah. And we check it once every 12 hours. Yeah. Doesn't seem like it would capture it a huge amount of time.
Right. But if you're doing rounds and you check it there, and then a shift assessment and the nurse is checking it, therapy comes in, they're checking it, and then we've got the evening shift comes in, they're checking it. That's like 4 or 5 different RT. You're coming to a breathing treatment or to do an RT treatment. Somebody's checking it there. That's 5 times throughout that day. The chances of us picking it up are going to be much greater when we're all, it just becomes part of, like on the unit, on the acute care side of the alert and oriented. And I'll tell my patients, do you ever wonder why everybody asks you these questions every single time? They're like, yeah, do they think I'm stupid and I don't, did they forget? I said, no, it's because if something changes with you medically, a change in your answers is one of the first ways we can pick that up, right? So a UTI, a new pneumococcus colonization, a new pneumonia, a new neurological, anything going on medically, very often a change in their thinking or a change in their mobility is the first sign that something's changed medically with them. And so by screening this through, it's going to help us pick up other things.
And it is important to let them know. I know you've been asked this, but it's important we continue. I have so much Crohn's disease, and the first time he was hospitalized as children, they kept coming in and asking name and date of birth, which I thought was a good thing. And after like the third or fourth person, he was like, Mom, like, do these people listen to me? Do they think he was losing confidence in the medical staff because they were asking the same stupid question when he was 13. But it was interesting. I'm like, no, actually, that's because they're being safe and they're making sure I explain why, and that was all he needed to hear. So I think that some of that time we are repetitively asking important to tell them why, because they don't think we're dumb.
Spontaneous awakening trial. What do we do with it? Once we know that they have a RAS of -2 or -3 or even -1, what do we do with that? Do we want to try the spontaneous awakening trial? What are the criteria? So the first thing is the safety screen. Is it safe to do an SAT? There are some patients that deep sedation is indicated for, right? If they've got active seizures, do we want to be waking them up? Probably not. If they're going through alcohol withdrawal and they've got DTs, do we want to be waking them up right now? These are the indications for the deep sedation. Escalating sedation for agitation. Is the patient on paralytics? Do they have active myocardial ischemia? Does the patient have normal intracranial pressure? So again, these are the defined criteria for deep sedation through the Society for Critical Care Medicine and the AHRQ. That's where this information comes from. If they don't have any of those things, proceed with SAT. Or is there anything that we should be considering? So if the RAS is anything other than 0, and they are on sedative medication, let's see if we can get them off the sedative medication, unless they fail the screen. So SAT, they fail. Residue rate greater than 35 breaths per minute for at least 5 minutes. Oxygen saturation less than 88% for at least 5 minutes. So again, if their O2 stat is dropping and they are appearing more confused, or their color is draining, or they've got COP, if there's anything we are worried about clinically, this criteria does not stand alone without clinical judgment. We are all making those clinical decisions case by case on every patient, right? So if the patient has had major perfusion issues and has had, we might be a lot more conservative. But these, again, I want to give you the criteria that have been set by AHRQ and Society of Critical Care Medicine, and then we deal with it on a case-by-case clinical judgment. If they have got acute cardiac dysrhythmia, that would be a fail for the SAT. If they've been on a normal sinus rhythm and we stop the sedatives and suddenly we're into AFib, we're into other rhythm issues that are dangerous, obviously that's a fail. We've got to start that at 50% of the dose they were asking for. Is it appropriate to increase sedatives so that my patient will sleep well through the night? The common myth among night shift nurses. I'll just up the midazolam a little bit. I'll just up the fentanyl a little bit, make them comfortable for the night. Is that an appropriate action? No, absolutely not. It is not sleep. It is living hell for the patients. We have to remember that medication-induced sedation does not equal sleep. Very, very important for us to know.
Does precedent count here
Yes. Yep.
Because a lot of people are on, we use that, I think, a lot because people are like on Precedex, but they're still kind of a lowish RAS and it kind of keeps them chill, but like it's still able to stuff. And sometimes we activate people on Precedex.
Right. And that is appropriate if they need it.
But we have to stop it before we did the SAT according to this.
Well, the SAT would be stopping the sedative medication, right? That is the SAT is.
So it's not just, it's stop, it's not lessen.
Right, it's an interruption of, the definition of an SAT is interruption of the purposeful sedation of that patient. Now, what they recommend is that we don't start a new drip, that we use boluses. That's the kind of the thinking from Society of Nuclear Medicine. You use the medications, and I'm not an expert in medicine, so you might be able to jump in here with what are some of the more appropriate ones that have a shorter half-life. We can stop them faster than the longer acting medications. So Versed, propofol, Precedex, those are all some of the ones that are used a lot. The benzos we know are the worst ones for causing delirium. So if we can stay off of the benzos as much as we possibly can, that is recommended. But sometimes they're needed. Sometimes they are medically indicated, and the risk of not doing it is worse than the risk of prescribed. So that's where your role as a pharmacist can come in and think, what if we try something different on a bolus level rather than a continuous infusion?
We had talked about that, the drip versus the bolus, and what do you consider sedatives? I guess that's part of, I think, where you're coming to. So would a bolus of these drugs not be considered a sedative where a drip is? Do you know how they define it?
So how would you define that from the pharmacy side? If you use an anxiolytic, right? If you use, what are some of the examples of the anti-anxiety drugs? So some of the anti-anxiety drugs have sedative effects, some don't. Can we choose one that doesn't sedate the patient rather than choosing one like a benzo that does cause more sedation and causes them to have those lower consciousness scores? So ultimately, if we can avoid things that are going to depress the central nervous system, so that's what altered consciousness is a depressed conscious state in the central nervous system. If there are alternatives, what are some of those that we can look to?
I have a question with that. I feel like that's one that could be kind of gray because I feel like if we stop precedent, patient's going to get agitated, they're going to fail. So are people just going to not do anything else when we could maybe decrease it a little bit, but still walk a patient on precedent?
But it's a hard stop here.
I know that's what I'm saying. So it makes it challenging because it's a hard stop and they quote fail because of agitation or cardia or whatever. Are people going to stop completely and not mobilize that patient because they quote fail? So I know, and I feel like we don't really do awakening trials on patients that aren't intubated. So we have a lot of patients on Precedex that can still be delirious, but we don't necessarily do this because we're not trying to.
Right. So they can walk on Precedex.
Right.
They can get up and walk on it. And if you look at this mobility algorithm here, if they're opening their eyes to verbal stimuli, they could be a RAS of -2, -1, 1, even +1. They can still walk on mild sedation. They can still mobilize. Your spontaneous awakening trial is when do I make the decision to get them off of all the things, right?
But they have to pass the spontaneous awakening trial to do early mobility. But they won't have the spontaneous awakening trial if they're on a continuous.
If you start and they can open their eyes to verbal stimuli, you can go on to.
So you're saying we don't even have to stop
right,
mobilization?
right, to do early mobility.
When I go in the room, I don't need to turn off.
If they're a RAS of -2 to +1, then you can mobilize those patients, whether they're on medication or not. Right? You start here and this one arrow here, if this is the answer, you immediately go to your mobility criteria.
So this term is a little bit confusing in that way.
Okay, we could redo it to make it more clear. If it's confusing, we can. No, no.
I don't think that we do, but I just want
That's
to make
good
sure.
that we have this discussion. No, if they are -2, now if they're -3
Try to turn.
or -4, you're not going to be able to mobilize them at that level, right? So you've got to try to turn it down to get them to -2, -1, where we can mobilize. Right? So just like your spontaneous breathing trial, that's different from your mobility. You can mobilize patients on the ventilator, but your criteria for removing the vent is different. Your criteria for removing Precedex and all the sedatives is a different set of criteria. We're screening them for delirium. They're CAM negative. They're RAS in the target -2 to 0 RAS. We're up and walking. There's going to be a time when we can get rid of some of those medicines. That's going to be a medical decision based on their medical condition. So let's look at what their own sedative wise. Can we lighten that? Can we get them to that -2, -1? And then we make that decision daily. Is it time to get rid of all of these, or do we need to keep them on that? That's a medical decision. Right? Did that clear that up? It's good to have that discussion because we're not the only ones who are going to get confused by it. If they open their eyes to verbal stimulation, like -2 to +1 RAS, they're safe. We've passed that bit. Let's try mobilizing. Let's look at the inclusion criteria. Are there any worries here that we have to be very, very cautious about? Let's figure out what we need to do to get them to where they can be tomorrow. If they meet all of these inclusion criteria, let's start that mobility process. Let's plan to mobilize them, all right, with the team. How are we going to do that? When is PT coming? When do they get their pain meds? When is RT going to be in the room? Let's plan those events, and let's move through actually the checklist that we talked about.
So my question is about timing. I know it's kind of complicated with, setting your medications and a lot of them, they have different half-lives. But I'm wondering, like, okay, I call a nurse, I'm like, when you stop at the station, she says, I'm going to stop at the station at 10 a.m. When can I expect that they'll be more awake?
So that's where pharmacy is going to come in, or the nurse to say different medications are going to wear off more quickly, right? So whether we're reducing it or whether if they're already at a RAS of -2, -1, they might not be stopping the sedation. They go, you know what, no, we're not going to do that, but come on up, they're ready to walk anyway, because they meet the criteria. But if we're doing the sedation vacation, hey, it's going to be half an hour after we stop, that would be the best time to come in. Bruno, would you agree with that, Lisa?
Yeah, for sure. I mean, it depends on how the data they are doing. If they're like, -1, -2, then probably wouldn't, but obviously if it's like -4, then it's going to take a little bit longer.
Yeah, and that's where those conversations are ongoing between the team members, right? There's not a one-size-fits-all for every patient. It's going to take some time of having these conversations within the team members and figuring out, and you're going to start more conservative. Right, and as you start to get people sitting up and you start to get people standing up, you're going to get more confident in it, and you're going to start to know the different parts and the different things and the different half-lives, and you're going to establish a rhythm of your mobility in your ICU.
What do you guys do now?
So when I do rounds in the morning with the therapist, so they're not nurses, if their patient's appropriate, and I notice the resuscitation, I'll ask them, like, are you planning to do resuscitation today? And what time we kind of combine, like, pick a time so that I can be up here, like, maybe writing notes outside the room and wait.
Yeah, so you'll just kind of see the way our schedules work, it'd be very hard to try to keep your productivity in the morning as best I can.
Rounds and decide that.
I think, thank you all for your attention, and let's start doing the CAM, the RAS every day. Think about the conversations we've had today.
And redo some of these to make it easier for you.
Yeah.
If you feel like there's a better way of
make it yours and make it workable. Take anything that I presented, you can change it, make it yours, make it work in the flow of what you
And don't fall on these wires on your way out.
Well, I will see you guys again in May for part 2.
Yes, beginning of May.
Beginning of May, yeah.
We'll have to go see you guys in a couple minutes.
And I think we'll see you in a couple minutes.
Yeah.
Right?